in Kingston, which is about 2.5 hours east of Toronto.
Okay, so
like halfway between Montreal and Toronto.
Okay.
If I drive directly here, it's 7 hours.
Okay.
But it's an easy drive.
Yeah,
It's
feasible, right?
Yeah, it's not. And if you have to take 2 flights.
2 flights, yeah, no.
And drive
And
for
like
45
all of
minutes.
these people.
Yeah, I just. Yeah. Have you had COVID here?
No.
You're fine.
I haven't. I'm telling you, there's a new study out from UCSF came out this weekend, and they're saying there's certain people that are like, if you have COVID, you might have a mutation in one of these genes. You can't get it.
I'm just hoping that I am like some kind of super, genetic beast.
Super dogs. They're called super dogs.
Yeah.
Super dogs. Because
That's what I
they
want.
have a mutation where when you get it, it just turns into a cold, and you don't actually get the COVID infection.
Yeah.
Sorry. Yeah. So I think I have that too. I think I'm a super dog.
We'll get started at 5 minutes past, so in maybe 2 minutes. Oh, am I on? Oh, I'm on now. I'm on now. I'm always on, just for the record. Hi, everyone. Thanks for joining us again. So we have our next session, and somehow I'm moderating again, so I hope you don't get too tired of me. Our next session is Bias in AI for Cancer Research. So our first speaker is Dr. Tina Hernandez Busard. She's an associate professor at Stanford in medicine and bioinformatics. Her background and expertise are in the field of biomedical informatics, health services research, and epidemiology. In her current work, she develops and evaluates AI technology to accurately and efficiently monitor, measure, and predict healthcare outcomes. She uses multimodal data sources to capture the patient experience, to improve outcomes, healthcare delivery, and guide policy, with a focus on the equality and equity of AI in medicine. Thanks so much, Tina. Here we go. Oh, do you want the microphone?
Yeah, I got it
You
here.
Okay.
Turn it on. Okay, does that work? Can you hear me? All right. Well, thank you, everyone, and thank you so much to the organizers for having me here. I think it's been these past talks we've had last night and then this morning have really set the stage for what I want to talk about today. So I'm going to build on the energy we've already started to hear, and I'm going to walk you through an approach that we've been looking at to think about developing fair and reliable AI methods for healthcare. These are my disclosures. I'm lucky that I have grants from several different agencies. NCI's in brackets because it's up and coming. I'm very positive about that. So as we know, the rise of digital data in healthcare has given us opportunities to really use this information for data-driven healthcare to improve diagnoses, treatments, treatment options, et cetera. And literature suggests that a lot of these technologies now either are approaching or exceed clinical performance of clinical experts. And this is certainly true in signal processing, image classification, medication errors. And so the hope is that we can develop better personalized healthcare for each unique individual. However, we know that that's not the case, right? We've seen over and over again that AI doesn't benefit all populations equally. And this isn't something new. This is something that's been, emerging in that literature for some time now. One of the first examples, or a good example, was when we started developing triage tools in the ED for heart attack symptoms. Now, what happened was the majority of past clinical trials were male-dominated. And heart attack symptoms between males and females are very different. So males have the chest pain, as where females might have fatigue or indigestion. So what happened was these triage tools were developed using the common symptoms, right, which were the male symptoms, and therefore they did not perform well on females. So many females were underdiagnosed. The performance really failed when we were trying to use these at point of care in the emergency department. And it also started breaking that trust barrier between the clinicians and the developers because they weren't reliably working. We've seen similar things in facial recognition, in melanoma tools, right? So majority of the tools that detect early stage melanoma were developed on fair skin patients, and therefore they perform very well for anyone with fair skin. However, when we try and have them perform on patients with darker skin, they miss the melanoma, they don't have the appropriate locations they're looking for, and the age at time of onset is also off. So this really highlights, this growing problem we've seen in healthcare. And then you probably all have heard about this study, which was the Obermeyer study that was in 2019 in Science. And this really started everyone saying, whoa, wait a minute, what's going on here? AI's biased, AI's bad. And so what happened in the Obermeyer paper was they used Optum data. Well, so Optum data has been used to allocate healthcare resources across many healthcare systems. And so in this algorithm, what they did was they used healthcare spending as a proxy for healthcare need. So they said, okay, we're spending a lot of money. These people who have a lot of money spent in the healthcare system, they're the ones who have the greatest need. Well, we know there is a systematic bias in our healthcare system that we spend less money on black patients than white patients for the same level of severity of illness. So the algorithm predicted costs, not needs. And black patients in this algorithm that was implemented across several healthcare systems had to be sicker in order to get the same amount of resources as the white patient. And so these biases then get reinforced by these algorithms, right? Because we're saying once the algorithm is implemented, the black patients are getting less and less resources for the same severity of illness. So it's this cycle that we start developing and integrating into our system. So biased medical AI is when we have computer systems that systematically and unfairly discriminate against certain individuals or groups of individuals in a population. A lot of focus on race, ethnicity. That's not the only populations that get biased, right? Rare diseases, age groups, pediatrics, there's so many types of biases. And there's two types of allocation of harm that happen with these AI biases in general. One is allocation harm. And so allocation harm is when the system allocates or withholds certain groups of an opportunity or a resource, right? So allocation harm can range from small but significant and systematic differences all the way to complete denial of treatment. And then the second type of harm is representation harm, and that occurs when systems reinforce a subordination of some groups along the lines of identity, right? And so we see that a lot when we're searching information in the medical system for, symptoms associated with diseases. One of my students came and said, I was looking for eating disorders in males, and they kept, bringing me to, is it menopausal or menstrual related, all of these things, and he couldn't find the right information. So similarly, as we think about, picture a data scientist, we have been reinforced, and if you guys haven't seen this film, I highly recommend it, but we've been reinforced that scientists are males. And so this is part of this representation bias that happens. So how do we develop fair and reliable AI models in medicine? We've been thinking about this a lot, and we've come up with this holistic approach in AI and healthcare. Now, we have these 5 components that we like to think about, and I think this really brings together a lot of the lectures we've heard earlier today and last night. And ask me back next year, and I might have 10 new components of it, but this is where we are today. And so what I want to do is I want to walk you through these different components, and I want to help you understand how bias and justice enter in each of these components of the cycle, and they each contribute to the biases we see downstream. And it's a cycle, right? And so a lot of times we focus on one particular element, so maybe model development, but really these biases enter in each phase. And so this is work that I was hoping it was be out before this meeting, but it's coming out in Nature Medicine. This was done by a postdoc in my lab, and so it should be out anytime. So I want to walk you through these different stages, going through each phase. So the first phase is data creation and origination. So this is, how data were produced. Did they come from an electronic medical health system? Did they come from a data registry? Are they commercial tools? Because each of these data sources, data originations, come with their own sets of biases, right? So I'm from Stanford University, and so I can use our data as an example, right? If I'm using my EHR data to develop AI tools, and then I take those tools and I try and deploy them at Morehouse, for example, it is a different population. It is a different set of circumstances. It's a different set of social determinants of health. It is not going to work. And so we need to take those into consideration. Where are these data obtained from? If I'm using smartwatches to detect fatigue after cancer treatment, you have to think about who has those smartwatches, who has access to those data, what are the biases that are, or representativeness of that data set that we ask our questions. And those involved in data creation should really draw attention to areas of under or misrepresentation, and also really be transparent in any attempts they've made to kind of equalize that representation. So we had an article come out a couple of years ago where we talked about data capture and a captive data framework. And I really want to focus on this data capture piece, because what we try and do is we try and take not only our medical records, but we try and link them to disease registries. We try and pull in survey data. We try and pull in RCT data, so we get a broader picture of our patients or our population. It's very hard to use one siloed resource and make a tool or an algorithm that could be generalizable across populations, all types of populations. So the next component of the AI life cycle is data acquisition, and this is how we obtain and consolidate information. So, and we were just talking about this in one of the early lectures, is sort of that data fit for purpose. So what happens generally is I have a grad student who comes to me and they're like, okay, I've got this great question. Here's the data I have, so I'm going to make this data fit to answer my question. And I'm like, no. That's not the way it works, because you can't, there's only certain types of questions you can ask of these different data types. So again, I'll use my example at Stanford. We do not do a good job of capturing emergency department visits in our area, right? People come to Stanford Tertiary Care Center, they get their treatment, and then they go home, which may be 3 hours away, 4 hours away, 5,000 miles away. And so capturing ED visits after treatment is not something we do a good job at capturing. And so you need to know these constraints and these potential biases that are in the system when we do this. Also, there are legal and mandatory mandates that tells you what data you can and cannot use. IRB constraints, so for example, in my IRB, I can't report anything that's less than 10 in a cell. So when we think about grouping and aggregating information, there's often that grouping of small cells so that we have enough to publish this information. And so as data changes hands, right, so we've captured this data, and then I might share this data with other students, other people, this information about consolidation and how we built these gets lost. And so I just want to highlight this, race other. We've all seen that. We probably all used it. What is it? It's a component. It's a category where we don't have enough of a certain individual. We don't know enough about certain race types. And so it's important to know that mixed race was the fastest growing race category in the 2020 census. So we really need to think about how we define those rules and regulations at the regulatory level, at the IRB level, and also how we start defining race and just collapsing these into these categories that really don't mean a lot. It's a way for us to make our models work, but how can a clinician use this? If I go to them, I'm like, okay, race other has a higher probability of treatment failure. It's not meaningful. So these are some things we think about when we think about aggregation of data. And so data is, we've seen a lot of talks about data and biases in data, and I want to just highlight some important types of biases we see in data. We have historical bias, and that's like underlying human prejudice in the data. So in the Obermeyer paper that I showed earlier, the algorithm wasn't biased. The model wasn't biased. There's historical bias in the data they used. So historically, Black patients have received less money for health care than whites in the past. And so that's what the data is. It's historically biased. So when we use that data, our algorithms are going to represent that bias. Representation bias is when your sample does not represent the population to which the AI will be applied. So, for example, a lot of times we take models developed in the adult population, and we might try them on the pediatric population, things like that. So understanding representation bias is really important. Measurement bias, we talked about noise. A lot of times we have all this noise coming in our data. Measurement bias is when that noise is not equal across populations, right? And so we might have, in the All of Us research cohort, we've been looking at that. And there's a lot of noise in the surveys for particular populations. So when we're asking about trust with providers, seeing things like that, you can see these systematic differences in who's reporting that information and who isn't. So measurement bias is when data noise does not equal across populations. And then aggregation bias is when we combine populations whose underlying distribution of disease, of the outcome, is different. And so that could be, for example, our race example, where we just merge these different categories together and assume they have the same underlying disease. So the next component is model development. And a lot of people spend a lot of time on model development, so I don't want to spend a lot of time here. I do want to highlight, and this is something we brought up in the last lecture, is model development is really about thinking about that research question. What are we asking, right? Who's the target user of this model? Are we developing a model for the clinician, for the system, for the patient? It's really important that we clarify that so we know who is the end user. Data labeling is another really important piece in model development. So, and I'll talk a little bit more about that, but it's really important that we have model tuning and training, of course, and calibration. But it's really important when we're in this phase, model development, that we think about the entire healthcare ecosystem. And we have representation from all of these different components. We need the bioethicist, the epidemiologist, the frontline clinician, having perspective from each of these different stakeholders is really important to ensure you're asking the right question, to ensure your question is meaningful, and to ensure there's a mitigating action. Somebody can act upon that output. And so team diversity is something I think that's really important when we're developing these systems. because team diversity is really the cornerstone for us thinking about how we're going to address some of the existing biases and equity aspects we have in these models we develop. So there's some evidence emerging that shows diverse teams lead to products that better serve the needs of their community. They better anticipate likely impacts across the community. And so if my group of designers are representing only one particular piece of the population, they're not going to understand how that outcome or that output of the model is going to affect different populations. So really important piece to think about. And then team diversity can also aid in broadening the actual questions addressed by AI. So recently, our healthcare system came to us and asked us to predict no-shows for a particular clinic. They're like, oh, we have this one clinic and it's got really high rates of no-shows, so we want to develop an algorithm to predict no-shows. So I went to my team and I'm like, okay, what do you guys think? And somebody raised their hand, like, well, why don't we predict, what are the barriers for the patient making it to that clinic? Why don't we flip the question? Why can't the patients make it? Is it the timing? Is it the transportation? So really thinking about the questions we ask, who's the beneficiary of these questions, is really important when we think about ethical AI. And team diversity is a big piece. And we just had a paper out just September 1st talking about how team diversity is really important when we think about developing ethical AI. And so data labeling, I don't want you to look at this chart, but I thought this is some new research we have coming out. And we partnered with a group in computer science at Stanford, Michael Bernstein's group, and they start looking at jury learning and jury diversity. So a lot of the NLP we do in clinical data is based on, well, all of it is based on labels. But when we're using clinical data, the labeling is coming from medical students, from staff, from maybe some clinicians, and we have them labeling these data. So in the jury learning by this group, they're saying, depending on how diverse your jury is, how diverse your labelers are, your classification model can vary up to 14%, right? And so this was something we looked at. So we looked at these 7 different reviewers. They were labeling depression in our breast cancer patients. And we had a range from, we had a diversity in ethnicity. We also had a range from medical students to graduate students to very senior oncologists. No, they were so far off. I mean, this was our interoperator agreement. Not so great. And so when you think about when you only have 2 people labeling your outcome, it's really something we think about, okay, I've got to find somebody who can label the most data at the most time. So really thinking about and really designing for the diversity of your labelers is really important when we think about fair AI. Because in our example with depression and cancer, we're looking through clinical notes, we're looking through communications. Well, if I have, the way, let's say, a Vietnamese woman of 40 years old expresses depression might be very different from the way our, a non-Hispanic white who is 50 and CEO at the company in Silicon Valley is going to express that. So having that diversity and having the ability to identify these differences in your labels can really change your classification and the output of your algorithm. The next phase is AI model evaluation, and here's where we see most of the literature. Here's where we see most of the information. And most AI models are evaluated on performance only. And so there's not really a comprehensive evaluation of fairness and equity that's systematically reported in the literature. And there's no evaluations as fully integrated tools in the clinical system. Right, and so I'll talk about deployment next, but we don't know, how do we deploy these models? What's the level of accuracy I need to bring this to point of care? Is a performance of 0.65 okay? Does it have to be 0.98? What are the standards we need to think about? And so, limited evaluations mask the potential societal harms that an algorithm might induce in certain populations once it's deployed. So I think we really need to think about that. And there have been some advances in algorithmic fairness, and there's three main components that are kind of stemming up for algorithmic fairness. That's anti-classification, where you remove a protected attribute and see how the model runs. There's classification parity, where we expect equal performance across different groups. And then there's calibration, where we expect agreement between the predicted outcome and the actual outcome in real time. So these aren't well evaluated in the literature. We've created a framework to kind of think about what are these different components and how do you need to think about them when we're reporting AI. And so this is a framework where we really talk about you need to look at missingness across populations. You need to look at outcome distribution, class imbalance problems. You need to evaluate things regarding performance, but also fairness. And so we've done a nice framework that kind of outlines all of this. Another aspect of evaluation is generalizability, and I know we talked about that a little bit at the last lecture. Generalizability is difficult, and I think it's a difficult concept that is being used across different societies very differently. And for generalizability, and this pyramid, I'm thinking, it could be flipped either way, right? I don't know what you want on the bottom. Do you want domain, generalizability at the bottom, or do you want that internal generalizability at the bottom? I'm not sure. I'm still kind of thinking through this. But generalizability is a way for us to show that our model is robust across populations. And so if I'm developing a model at Stanford and deploying at Stanford, and I'm not going to deport it anywhere else, I want to make sure that that model is generalizable in my healthcare system across my populations. If I'm going to take this to industry, I better be sure that that is generalizable across multiple populations, across geographic locations, across many different domains. So generalizability is another piece that we really need to think about. Model deployment is an area where I think we have the biggest gap in information for AI models. We have no real standards for when do we deploy, how do we deploy, where do we deploy information, who's going to monitor and maintain an algorithm once it is deployed in the healthcare system, whose responsibility is it? Bug fixes, things like that. Somebody has to be responsible for that, and we really just don't talk about that much in the literature about whose responsibility that is. And then downstream evaluations, post-market surveillance, as you want to look at it, is something really we need to do a better job at surveying and ensuring that we're not harming particular populations with these algorithms we deploy. And so this is a little delivery science solution that we use at Stanford. This is done by my colleague Nigam Shah. And they give use cases where you have to, before you deploy a model into point of care, there's these stop points at each intersection. Is this an outcome that somebody can act upon? Is there enough resources at the hospital to act upon that? What's the utility of the assessment? And so really kind of thinking about and expanding on these frameworks for when do we start deploying at point of care? How do we get these into these hands? And what are the stop points? What are the checkpoints? And then finally, there is explainability and interpretability, right, which really builds on the trust we have with the AI systems. I see explainability and interpretability at 3 levels, right? You have the engineering level. So when we give our algorithm to a healthcare system or to a clinician, the engineers have to understand how the model was made. How can they recreate that model? The clinician or the end user has to understand what outputs were used to give me or inputs were used to give me my outcome. That builds trust. Oh yeah, okay, yeah, blood volume, that's related to what I know that's there's evidence on that. It really builds that trust. And finally, how to maintain the robust system is really for the systems manufacturer, right? So they know how to survey, how to monitor, how to look at it. And so then that takes us back to data creation, right? Because we're deploying these models at point of care, we're creating data. And so if we're deploying models that are biased or unethical, we're generating data that is biased and unethical that goes back into our healthcare system. So it is a cycle, and I think that we really need to think about the entire cycle when we're thinking about these AI life cycles. And you know, I couldn't come here without talking about the digital twin, because this is some work we've done with Eric and Amber and a bunch of people here. And so the digital twin is this concept that we can take multimodal data. We can use that data to develop all different types of algorithms. We can take those models and look at predictions for patient outcomes, bring that to point of care, and then feed that new data back into our systems. And so if you think about my framework for AI Lifecycle, we have data acquisition, we have model development, model evaluation, the model deployment at point of care, and then we're back at data creation. So it's a way that I think we need to really think about how we move forward with these. And of course, this can't happen without open science. We were started off on this meeting about the concept about open science. None of this can happen without open science. We can't share data. We can't gather all the data that's necessary for us to build these multimodal partitions to develop the digital twin. And so I really think that we started off this conference on the right note with open science, and the metadata also that we talked about earlier is so important in how we get there. And so, you know, in conclusion, are some of the phases of the AI life cycle that we have identified, and the ethical issues, right? And we've got some recommendations for how we can improve these. Recommendations include transparency in reporting, expanding regulations so that we can think about data sharing and how we share that information so we understand the biases and the ethices. Developing a comprehensive metrics for evaluation before something gets moved into point of care, before it can start causing harm, and really developing focused studies on deployment and monitoring and downstream monitoring of these systems. And so with that, I'm going to skip that. I'm going to end with this slide. And so I've showed this slide before, and I love it because I'm like, okay, so it's all about equity and equality. And if you think about the Obermeyer study, right, the problem is that the black patients didn't receive the same resources as the white patients. So they're really striving for equality. However, when we think about it, you know, some patients might need more resources than other patients, and some patients might need less. So I think we can really use AI to better think about how we distribute resources. And so I presented this at a workshop at NCI back in March, and the patient advocate said, you know, that's fine, but what I see here is a wall. So what you're doing, you're not breaking down that wall. And I'm like, oh, that's such a good point. And so I found a new slide. I took this from Reddit. And so they have a reality where one component gets all the resources. You've got your equality and your equity, but then you have justice where you don't have that wall there anymore. So I thought this was great, and we really should be striving for how do we break down those walls and those barriers. And so with that, I will stop here. That's my contact information. I've got a great group of people who've helped me work on all of this, and so happy to take any questions, and thank you so much.
Thank you. So I really appreciate how you describe the difference between assessing algorithms based on performance alone,
yeah,
and then also taking into account the equity and fairness aspects. So I'm kind of a hard science guy here. So one thing that I notice immediately is that performance you can quantify, and then if it's insufficient, you can hopefully tweak something in the algorithm so that it improves, it increases, and again, you can measure it. Have you tried quantifying equity and fairness so that you can be objective about the improvements that you make in your framework when you set it up?
Yeah, and so I think that, you know, the data we have are biased. I mean, it's clear that our medical data are biased. And And so we need to think about a way that we can use them and apply them fairly. And so that might mean that, I might only be able to apply my models to particular populations where they have high performance. But knowing that they don't work in particular populations and knowing they're below a certain cutoff for performance, whatever that might be, and I think that's something that we as a community need to kind of understand.
So does that make sense to you, that it needs to be quantified?
It does need to be
fairness?
quantified,
Yeah?
absolutely,
Yeah.
absolutely, it does. And there's no real magic number right now, but I think that, again, we need to kind of think about what should that be, how should we quantify that? Absolutely.
Absolutely, I absolutely don't know because I'm not an expert. So I hope that experts figure that out soon enough, so that, it's AI, I think it's a quantitative science, quantitative technology. So I think precision can go beyond performance.
Yeah,
and
absolutely.
into those other aspects, and I think that's going to maximize.
Yeah, and that's what I think we need to think
promise and
beyond, just one area under the curve or ROC curve. We need to think about these other measures.
Thanks so much.
Sure.
Thank you for the presentation, and I like the slide where you were breaking the different sources of bias. And the one part I was really not understanding well is that how historical bias and representation bias can work together. So you're building the models with some data that might have some bias, but eventually when you apply it, the bias that was in the data is also where you're going to apply it. So how you can be fair for in the two sides, and it will be like maybe stratification of models, like building model for every group of people would be that way to solve that. That I would think a contradiction, but you can elaborate on that.
Yeah, no, so was there a question in there?
How historical bias and representation bias will work together.
What's that?
Historical bias and representation
Yes.
bias.
Yeah, can they work together?
Possible
Yeah, and so they can. I mean, well, representation bias, I mean, they're different, right? Representation bias means that we don't have the individuals in our training data that we're going to apply the algorithm to. So we're not learning the different nuances in these particular population. Historical bias is we just, we're not a great society sometimes for a lot of things. And that's ingrained in our data. And so, yeah, we can in representation bias, we can, there's different ways you can treat that. You can do either you can make your population equal, your sample equal to the population, or you can do a weighted population where every different component has an equal representation in the data set. Those are two ways we can address representation bias. And they both have pluses and minuses to think about that.
Would you build a model per population? Would that be a way to overcome it?
Build a model what?
Per population.
On Amber, you want to help me?
Per population.
Should you build a model per population?
It depends on how you're going to use it, right? It all depends on your end user. Who's going to use the model? How is it going to be used? If you're building it for your healthcare system, again, you want to make sure it represents your population. If you're building it for a particular clinic, you only care about that particular clinic. So it depends on the question. And that's how we can still use this data and still gain knowledge, even though it might be historically biased or non-representative, but we can still use it and learn.
Some of how we define these populations is inherently racist, right? So how do you want to define the population? Yes.
In your discussion of the model development part of the life cycle, you talked about the importance of the diversity of the teams that are developing the models, and you included patients in that. Sounds good. In practice, what does that actually look like? Do you have to have a diverse set of patients that are also included in all of this?
So in practice,
what are your
does it
development
look like,
teams
all of
actually
this
look like?
interdisciplinary collaboration?
It's fun. It's a lot of fun. For me, it's like the best part of science, right? But it's a lot of, we use terms different. I mean, it's hard. It's not easy. And I'll say, I was talking to Eric earlier, in 2019, he threw a bunch of us in a room together, and he said, you guys stay here for, 2 days and come out with something that you want to do in the next 10 years. And we were very diverse, different fields, everything, and even like the terms we used for a vector were different. The terms we used for population were different. So different terminologies, different disciplines, but we were able to come together and come up with some really interesting ideas, and I think it's fun. I think you have to have respect, you have to be able to listen, and you have to understand how these different opinions and voices can fit together into the bigger picture. It's hard, but it's fun.
So I think I understand that part. I'm just wondering, more practical, how many patients are included in a team of how many people overall?
How many patients are included
Do you
in what?
compensate?
In a team versus the number of team members.
You compensate
kind of thing.
them?
How many patients?
Oh, and do you
That's a hard one.
compensate? Yeah,
That's
yeah.
Patients are, we try and include them.
Do you
We
compensate
usually get
them?
one patient advocate if we can, and
Do you compensate your patient advocates? We have a lot of discussions about this
you know,
because
we just
that
had a
creates
discussion about this,
inequity.
and
Yeah.
I believe it was, you know, how much do you pay them?
Yeah.
When does it become unethical? It's a good point, and I think I haven't thought about that enough.
I can tell you our patient advocates are almost always white. And they're almost always at a later point in their career that they have some time to give back.
Yeah,
Yeah.
I think I've seen a diversity, but it's really important. So,
Okay, thank you
Okay.
so much, Tina.
sure, thank you.
And one more round of applause for Tina, please. Mike, come on up and get set up, and I'll introduce you while we're doing this. Lots to think about, lots of work to do. We have job security. You got it there? Okay. So turning now to my colleague, Mike Green. Mike's a family doctor. In fact, he gave me one of my shots, one of my vaccines, in a car rolling through the university. He's a professor of family medicine, a professor of public health sciences, policy studies at Queen's. He's also a senior adjunct scientist at ICES, and I imagine he's going to tell you about ICES. He was the inaugural Clinical Teachers Association of Queen's University Chair in Applied Health Economics and Health Policy, and he formerly served as the director of the Center for Health Services and Policy Research and interim director of the Queen's Health Services and Policy Research Institute. So to put this into perspective, somebody sent me to talk to Mike in my first week at Queen's, and whenever I talk to clinicians, it can be a mixed bag, right? What people know about data science and what they know about informatics. And I tell you, I've never met somebody, a clinician that knows more about how data actually works on the day-to-day for patients. So Mike, please take it away.
All right, well, can everyone hear me okay with the mic? Great, thank you. So thanks for having me at your meeting, and I'm not sure if that's a really low bar for clinicians in data science, but I want to talk, maybe move things in a different direction. This will be probably quite different from some of the other talks, and what I'd ask people to think about as I go through this is all of the work that's going on here is fascinating. You know, for me as a data scientist and a clinician, I think of all the applications. And as a family doctor, primary care clinician involved in certain parts of the cancer journey for my patients, I think about all the work that's going on here and how it could, oh, it's not turned on. And how it could, is that better? Can you hear me now? Yeah. Is it the same? No. Okay, there was a lag. Okay, so how the work that you're doing might help me help my patients in me doing a better job helping them through their healthcare journey, because that's for us in family medicine where we see the value and power of AI. So I'm going to run through it. First, I have a few disclosures. My disclosures are I didn't put grants and things on, but are more kind of for maybe where my biases come in terms of where I see the priorities. I'm a board member on a charitable foundation that does work in technology and compassion in healthcare. I'm on the executive of our National College of Family Physicians of Canada, which is like your AAFP. I'll be our president-elect in a couple of months. I host a data set I'm going to talk to you about, a primary care electronic health record data set from across Canada called the Canadian Primary Care Sentinel Surveillance Network, or CIPSEN for short, in my department. And I want to talk a little bit about some general perspectives of AI from the primary care point of view. A little bit about bias and equity, and I'm really glad to have seen all the other speakers do a fabulous job really dissecting down the different layers of equity, because these all matter so much in primary care, where we're interacting with so many patients from so many different backgrounds in settings that are ubiquitous across our healthcare system. And then I want to talk specifically about cancer and some examples of where we could really use the development of AI to help for cancer care and decision-making in primary care for our patients. And all of you who've presented on things like your different models and where it works, I'd love to see some collaborations come out of this where you think, you know what, that model that I've worked at for my cancer center or for my pathology thing or for my health system, how could that make its way into the primary care systems and services of the people that begin their cancer journey in the community to coming into a more specialized level of care? So this is from, we just had a summit on artificial intelligence in family medicine in Canada and try to set a research agenda. And these are the sorts of areas that are important for us in family medicine for applications of AI. Population health. How do we move from thinking about just our individual patient to how we're caring for a population of patients within our practice, including patients that we might not see all the time, like the people who don't come in or the people who we should be serving in our community who are left out. How do we get more operationally efficient? I don't know what it's like in the US. I suspect it's similar to Canada. There's a lot of press right now about burnout in frontline healthcare providers and the significant operational burdens and administrative burdens that are placed on people, often with solutions like let's hire scribes, let's do this, all these workarounds, because good data is important, but the work of producing good data is work. And the work of collating that data is something that often the AI for that is here. This is what happens with all the insurance forms and every other form for pre-approval and everything else that comes through my office. Preventive care and risk profiling, I'll use that as one of the examples. Screening being one of the most important things in terms of cancer care, but also early diagnosis and symptom recognition and early diagnosis in the clinic. Physician decision support, both for advising people on how to make an informed choice at points in the pathway where there's always values and patient preferences to be taken into consideration. How do we bring that in? And how do we help patients do better self-management and use these tools to deploy in the community to help with self-management and help them make better use of the health system and better use of our time together, as that's what I see as being my main job, is spending time with my patients to have that discussion and help share and translate information about their health status and the options that they have in front of them for decisions they need to make. And it's complicated. So we've spent, I don't know if this has a point, does it have a pointer? But up in the top corner where it says high quality AI-based tools, that's what we've been mostly talking about here today. These other things that are here are the things that matter to us as to whether or not AI is deployable and useful to us in family medicine. So this is a given to us that we need that external validity, the security, the freedom from bias, the high quality tools. Like that technical quality of the tool is critical. But so is, how does it affect the way that we work with our patients? How does it affect the relationship that I have with my patient? Those slides I love the slides from Osler and Hippocrates earlier about knowing your patient and your practice. Like that's the core of what I do as a family doctor. I'm not afraid of losing my job to AI because I think most people would rather sit down and talk to me than they will like to just put some questions into Dr. Google. And how does it support the quintuple aim of equity, patient experience, provider experience, population health, and health system efficiency and value? And then I also want to talk about governance and informed consent, because I think the hard part of this shared open data that we've talked about is not the technical side. There's technical solutions. It's the social contract, the agreement of the public, the agreement of the different stakeholders to want to be able to share their data for a common good, and coming to understanding of how to do that, and how to overcome the concerns of communities that suffer from bias, from prejudice, about the use of their data and who they are and their identity in the use of this when we're going ahead to look at how we want to address bias in AI in all its stages. I'm going to talk a little bit specifically, because it's been alluded to, but I don't think anyone's shown examples of how and why those kind of the bias of who is in it doesn't matter what it is, whether it's a test set or a deployed set, or whether if you're thinking about a risk factor and you're using a proxy, how closely the proxy actually represents the real risk factor they're using matters for the patients in the way they're deployed. A little bit about the importance of how that applies to a practice population, and we just heard that in the last case. How well does it apply at Stanford? So for me, how does it apply in my family health team? And spectrum of disease bias, even in terms of the outcomes and the risks. So that refers to, in my practice, my perception of how many people have a bad outcome from prostate cancer, for example, is going to be very different from a urologist, is going to be very different from an oncologist who sees complex metastatic cases, because our practice environment and how we see our perception of the severity of disease and where things are will vary. Development, a bit about values, objectives, and tools, and the reinforcement of inequitable care has already been talked about. Okay, so I put no labels on this for a purpose. I wanted to keep this just real simple. So in each of these circles, the red circle is where you're deploying your AI tool. In a broader system. There's always subgroups within that. So if I was to think like if we were to deploy an AI tool in our Ontario health team or in the province of Ontario, that'd be like my red circle, primary care in Ontario. The blue circle is going to be like my practice or my hospital or whatever it is. It's the more localized population. And then the other circle underneath that are the different colors are where the data came from to build the tool. And so what you see is, it's one thing if you've got mostly overlap and things are pretty well there. There's going to be some bias. Nothing's perfect. I made none of them perfectly overlapping. They never are. There's always going to be some risk of bias. But the further along you go, the more problems you have with bias in your system. And if you think about primary care in particular where I work, I'd like to just make a plea for people to think that any tools that are going to be used around prevention, survivorship care, early diagnosis have to be deployable in primary care. And so if the development is all happening in the far side where there's very little overlap, there's going to be major problems when we go to deploy. So how do you get around that? We had a couple of examples in the last talk about trying to do maybe some specific substrata of thinking of where your data comes from, pooling data, trying to get full population representativeness. And I want to talk a little bit about work that we've been doing to both get representative data from a range of sources to get some depth and multiple data sets to cover off some of those issues, as well as what we've done to try and bring primary care data into the equation. What's important to know, I loved your picture of your old red health card. I hope you have a green one, because those red ones are what create all the error in our data, because that's why we have more health cards than live people in our data, because the people with the red cards never want to give them up. The green ones expire after 5 years, and no one likes to go to a government office with photo ID and get a new card. But we have a universal single payer system. People don't understand it as well as they might. It covers 100% of hospital care, 100% of physician services, 100% of medically required imaging and outpatient labs. So there are some, schedule issues with particular items that aren't covered. But it does not cover all drugs, only for some people. It does not cover all home care. It does not cover all mental health, rehab, or professional. So it's still not a fully universal system. We're probably about 70% public spend, 30% private, not that much different from most of the rest of the developed world, just spread out differently. It's federally mandated but implemented at a provincial level. So we have data silos in our country by our provinces. And so our provinces are the main group responsible for healthcare, and also setting the legislation on healthcare data and data privacy mainly is at the provincial level. So that's kind of our biggest unit that we can easily go up to without running into significant issues around cross-jurisdictional data sharing problems. So the approach that's being used in some, but not all, of our provinces is to try and create data centers that will bring together all of the publicly available data around healthcare use, together with other bits, and they've been slowly growing, that are in these two cases, I think the two most effective ones in the country, and it's because they're arm's length from government. So they've been set up, both of these, through agreements with government, which is the main funder, but as an independent entity with its own board and its own governance and its own patient kind of council that has had a lot, there's been a lot of effort on diversifying the representation on those councils for the social accountability mandate. And then they hold all kinds of data that is linked at the individual level, and it includes all physician billing, all hospital visits, hospital expenses, a whole raft of hospital-based data, physician billings for all specialties, including primary care, labs, imaging done but not imaging reports, so that's something they're kind of working on, but then census, government-sponsored population-based surveys, et cetera. And now they're also getting into other data to deal with social determinants of health, educational achievement data. So what school district did you go to? How did you do in school? Did you repeat a grade? Did you graduate on time? Justice data, any experience with the justice system. Social services data, supports from home and community care, all those sorts of things are slowly making their way into these integrated data platforms. ICS, where I work as a scientist now, I did a check of our data dictionary before we came in. There's over 100 different data sets in the ICS repository that are all linked at the individual level by a person's individual health card number. So it provides quite a decent breadth of data for use with some AI tools, but it's lacking the depth of things like the detail. It doesn't have omics, it doesn't have images, it doesn't have those. It's starting to get some of those structured pathology reports through affiliations with our cancer group, et cetera. And it has been lacking primary care data, particularly primary care EHR data. It also has been lacking hospital EHR data, so that detailed clinical data on the patient experience for patients while they're in hospital. So how do we get past that? And why is it important? This has two figures. One is from the US, one is from Canada. So the black and white figure is from the New England Journal. It's come out twice, once in 1969, very first one, and then the update, what's the year, 2001. And it just shows for 1,000 people in a year, how many people actually have symptoms, about 800. But most of them just take care of themselves at home. Not everybody goes for every symptom to the doctor. About 327 consider seeking medical care, 217 actually seek medical care. Of those, 113 are with a primary care provider. And then you go down all the way to the bottom, that little small dot in the end is that one, less than one, is admitted to an academic health sciences center. And most of the data platforms have been built around academic health science centers. So my argument for this and those overlapping circles is we have to move from that little pointy corner as far out as we can get. And in health, you still can't get there because there's 800. There's a whole bunch of people who never encounter the healthcare system for that particular symptom, but most of them will go eventually. So if you include primary care, this is our other graph here from what happens in 24 hours in Ontario in healthcare. So this is an older figure. We've actually it's not published and out yet, but we've just updated it. The population's grown, so the numbers are bigger, but the proportions are all the same. At this point in time, it was for just under 140,000 GP visits in a day. There were then 54,000 specialist visits, 41,000 X-rays, 12,000 ED visits, and you see down to the bottom 50 hip and knee replacements. And so again, if you're wanting to get comprehensive data in big circles, the place to go is primary care for the data. And over time, this is in a day and in a year, but when we look at information on who visits in a kind of 2 to 3 year period, about 80% of people will have at least one encounter somewhere in primary care. So it builds over time a longitudinal access to people's other data. And we've used a network of networks approach for this here because there's this trust issue. So we organize, we're organized into that primary care sentinel surveillance network. Groups of practices, so individual practices give data to a regional center, and then the regional centers give the data up to the national center, and there's sets of data cleaning and harmonization around the way. with appropriate data governance at each level to allow the data to be used locally with fewer restrictions and more restrictions and involvement of people as you move up the ladder in order to make it available as a large set. And in Ontario, we've now actually made the next step with our Poplar network. There's these different groups, which you don't need to know exactly who they are, just there's about 8 of them that work that are all sharing EMR data. We now have moved to common extraction. So we actually have now gotten to the point in our relationship of working together for a long time that instead of each of us doing our own extractions with each of our vendors, we now have one of our sites do all of the technical extraction and share the data across to all the sites. And now this information can now be linked to our administrative data, those other 100 data sets, and this starts to bring that depth of clinical information from primary care into the larger data centers with the hospital and claims and other data. So that's how we're trying to do that. There's some real issues with AI. Still, people are worried about burden of work. It has to integrate into EHRs for people to use. If they're standalone tools and websites, people tend to not want to use them. The data availability and quality has been discussed. And in primary care, our data is very messy. I looked at the pathology report discussions earlier with NLP. Pathology reports still are mostly about one thing and have a limited set of terms and numbers and things that are going to be described. In primary care data, it's every problem from every person in every situation, and everyone has a different way of referring to it, and there is no way that people want to take the time to codify the data very well in practice because of the time constraints in how people are doing their work. So even something simple like diabetes, we did a look at our own data in some kind of free text on how people say diabetes. We came up with I think 14 ways that diabetes was indicated in text in patient charts, and that's one condition. So if anyone here has great ideas about how to deal with that really messy, complex data and codify it, this is something we really need. And trust, the ongoing provider and patient buy-in is critical. So everything has to be done with the lens of, if this goes badly and this is something that would become a public outcry about the use of the data, how would that impact the progress forward? So things have been a bit slow. They're a bit conservative on how you get to sharing data and getting it out, but it is very critical if it's going to maintain forward momentum. Because this is not possible with consent-based systems currently, where every individual patient has to consent. Automated tools like this in these kind of data need to be deployed at scale for everybody, and that's not possible unless you have a social contract where people are agreeable to the use of their information and data in that way. And I'll skip this. This is just a little bit. I actually really like this article thinking about how AI can affect clinical thinking, because I think this is a piece that's how will AI be deployed and what do clinicians need to use about it and how it's kind of going. But I want to talk more about these. How would this actually roll out for cancer care in primary care? What kind of questions are we dealing with? This is the simplest flow sheet from our task force on preventive health care on who ought to get a mammogram. So you can see there's a bunch of little bubbles. There's different pathways to go through. But for me to do this in the office with a patient, I first have to take out this. And the patient can look at this before, saying, should I get a mammogram? And it says, go see your provider, that little red box. So they come see me. And I'm supposed to go through this with them. These are our 1,000-patient tools. If you're not a clinician, this is how we think about the impact of an intervention like screening on a patient. And this is where precision medicine would really help us a lot. Because what we're trying to do for people is if you just look at the colors, the 1,000 people are all there. The gray are the people where nothing happens, like they had a negative screen. The blue ones are people who had a screen and it was worth getting it done. They had a follow-up with something that was worthwhile, even if it ended up being negative. They definitely needed a biopsy. The purple are people who ended up with an intervention that wasn't necessary. And then in the other box, the yellow, red, and greens, the yellows are the people who had cancer and they died from cancer regardless of the outcome of their screening. There's some reds where people had, just trying to get into the thing, they were treated for a cancer that never would have bothered them. It was a slow-growing early cancer, and they got treatment, but the treatment was not necessarily in their interest for survival. The green is the person who benefited from screening and was the avoided death. And so our job is really to try and balance out, particularly the green, the red, and the purple, and say, when does that balance for an individual patient switch so that they can make a decision, yes, I should go get this test, or no, I shouldn't. These are very crude tools. They are not individualized to individual patient risk. They don't have all of those other factors. They don't think about things about, what's your breast density? They don't take into account all of the things in family history or past medical history, et cetera. They're for what they call average risk. But average risk is averaged for the whole population, and we know that's not true. So if you think about all these things, how could AI help me make a better one of these for my patients so that they can make a better decision about a screen? So we end up with more of the green and less of the red and the purple. That's really what we're looking for. And how could we do that? Automation. So automation of pulling in the information that's required to help identify an individual person's risk in one of these. Refining risk and building in patient engagement for what's important. Because these sorts of things often surprise patients as they see them the first time. It'd be nice if they had some self-assessment tools at the beginning that assess their values for care that would say, you're more of a person who prefers aggressive treatment, or you're more of a person who does not, because there's quite a range. And this only works if we have fair data without significant data gaps. And outcomes and historical bias are important, because if you're in a population group that has poor outcomes because you've been discriminated against, then the algorithm will suggest you won't benefit from screening or treatment, when in fact that may just be because of the bias in the system. Next case example is just, we have these diagnostic pathways for every condition in the world. This one is for someone who has an abnormal blood test suggesting they might be at risk for myeloma. And if you look at all the pathways and boxes, this is a lot of work. Every time I have a patient who gets a mildly abnormal blood test on one of these things, I have to pull this out, go through, order the test, do it. How could AI help us do this? How could you automate these flows for us and help us understand when it's correct? And for precision, the subpopulation issue is important. Even if you have a representative pool, if the tool that you're using is not equally effective for each subpopulation, the value of the recommendation from the tool is going to be different. And so this was an example from chest radiography, where they found that prediction of pneumonia was different, just simply based on different subpopulations, because probably because the baseline chest X-rays were slightly different, and the differences the AI was looking for were different in the different images. And then the last one I want to do too maybe runs through the spectrum of care from what I would consider easier to harder for AI to do for us. This one is for survivorship care, and this is a toolkit for what we're supposed to do for survivors of breast cancer in primary care. The first thing is fill out this sheet. This looks a lot like that pathology sheet. Right now, I personally have to go in and type in all of those fields, and I have to search through about 6 or 8 PDFs of different reports from the surgeons, from the imaging reports and everything, to get the information and put it in here. So if that could be automated with the NLP and come over from things like automated pathology reports, this would be a big step forward for us in understanding our cancer patients. The next one is surveillance for afterwards, which are the guidelines for following them up after. For each of those patients with a mix of tumor types, there's different recommendations for aftercare. Could those be embedded into our electronic health records for prioritizing recommendations? And then finally, what about symptoms? And I think this is the most exciting but the most difficult. In a post-cancer patient, how are the symptoms they present with different in terms of the potential diagnoses for recurrence or other primary cancers compared to any other average risk patient who I'm seeing in my practice? And so this is going to require a lot more work, but I think it brings us to where we would really love to be at the end of the day. So we have a long way to go. There's very little involvement of there's some primary care AI research, but not that much, and very few primary care providers actually involved in formulating them. So the inclusive part of your team, I would just say, there are people interested in it. Reach out. They would, I'm sure, love to collaborate, and I think potentially bring some interesting insights as well as access to new sources of data. And it's an issue here in the US too, so I presented mostly on Canada, but this is from a paper that just came out from this is from the Graham Center and the American Academy of Family Physicians on what they see as the priorities for developing AI in family medicine in the United States using this ideas framework. So they're built on the quintuple aim, but that the infrastructure and data needs some investment. Delivery transformation is important. We talked about evaluation here already. That the algorithm development needs to include patients and primary care data, and a social justice lens on developing AI and ML, because this is, I think, for primary care physicians, one of their major concerns is the social justice and bias issues, given those sort of scope of data that many of the algorithms are built on early on. So I'll stop there. Thank you.
Hi, Mike. I'll be going right after you in a second. Really enjoyed your talk, as I did enjoy Tina's as well. Really great intro to what I'm about to talk about. With regards to your concern about how hard it is to kind of contain all of the ways in which particular conditions can be described, because there are so many different ways to, for instance, document diabetes, to what extent have you all, again, because you have a relatively closed system in Canada as opposed to the United States, investigated limiting what options providers can actually use to describe a condition? So behavioral economics nudges, basically eliminating options so they can't be chosen, and therefore it limits what can actually put into the system. So that's something that we're working on in a particular unit at Penn in terms of how you can order a mammogram. Because if you give people infinite options, they will use them all. And so we're trying very much to basically narrow down what can be chosen, and therefore they won't be able to pick the wrong thing, and it makes it easier, therefore, to abstract that data later on. Thanks.
Yeah, great question. And this is the challenge in balancing the feasibility for implementation in terms of how the workflow of clinical care with the quality of the data. So how much time do you spend trying to turn family doctors into coders? And how much time do you want to deploy tools to code the data that they put in? So for some things, it makes sense. Ordering a mammogram is great. It's a good example. It's probably faster for me to order a mammogram where I can click on diagnostic options on a box that's coded for why I'm ordering a mammogram than it is for me to write it in free text. Same for common things like in a chest x-ray, there's a whole bunch of things like that would be nice. Same with ordering lab results and billing. Those are all nice structured data, easy for me to click and be forced in. In the free text part of a note, very difficult. Family doctors hate EMRs that are overstructured, where they have to pick all of the things off because it increases the time of work that they're in there. So it's really a balancing act between efficiency and data quality.
You quickly touched on a very complex area of informed consent, because it's sort of a landmine kind of problem, especially when you're dealing with specialties and different levels of care and so on. But now, exposing a lot of the data to AI methods and qualifying the informed consent to allow research, have you started to look at what happens when you get unintended consequences of the AI research turning up and feeding the need to feed back diagnoses that weren't originally considered by the patient or the physician?
Yeah, no, that's a great question. I think it depends on, we see a lot of these sorts of studies where it's things looking at quality of care, whether it's people following treatment guidelines or whether it's people missing diagnosis. In a research environment, if you have the right people at the table with a focus on how do you improve things, that's helpful. You do have to differentiate it from the kind of production environment. If these tools are being deployed in a health system live for patient care, I think the idea is to try and find those things early, like give the reminders. Do you think you missed this? And those things can be helpful as long as they're not, don't cause too many alerts, because we've also learned that alert systems for doctors get turned off if there's too many what they consider to be false alarms. And so really, I think the same approach to engaging patients needs to be with engaging clinicians. They need to be there talking about what will help. There needs to be a diverse range of them. They can't be only a small group from the academic center that's keen to do it, or only the hospital leadership that's going to be enforcing it. Otherwise, you're not going to get much buy-in or use of it.
Any more questions for Mike? Let's thank our speaker one more time. Great. Continuing on our wonderful session, we have Dr. Lola Fainu, is the Helen O. Dickens Presidential Associate Professor in the Perelman School of Medicine at the University of Pennsylvania. She is the Chief of Breast Surgery for the University of Pennsylvania Health System. She is also Surgical Director of the Raina Rowan Breast Cancer Center in the Abramson Cancer Center, Director of Health Equity Innovation at the Penn Center for Cancer Care Innovation, and a Senior Fellow of the Leonard Davis Institute for Health Economics at the University of Pennsylvania. So please join me in welcoming Lola. Thanks.
Good. Can everyone hear me okay? Great. Well, thank you so much. It's a real honor for a simple surgeon like me to be at a conference full of data scientists. But I have a few disclosures. In addition to funding listed here, I am a lapsed programmer and literature person. My father insisted we all learn quite a lot of computer science. So I care about data a lot more than the average surgeon. I care about where it comes from, how it's stored, how it changes over time, and how it allows us to tell stories that can fit the narrative we want to hear. And at my previous job, I spent time devoted to compiling data about women with breast cancer in order for us to conduct retrospective studies, and really spent time grappling with the challenges of how to corral data, how to get wayward clinicians to put the data in a form that allows it to be corralled, and then how to actually analyze it in a form that leads to meaningful conclusions. And so that is to say is there's a lot to be gained from people like you working with people like me, because believe me, people like me are not good at putting data in a form that allows you to work with it. And so I'm going to just explain a bit of why it is so hard to get data in a form that is usable, why patients may not want to give it to us, why clinicians are not good at entering it in a usable form, and how we can work towards doing better at both of those things. So I wanted to start with a couple of definitions. So diversity and representativeness. So one, what is diversity? It's a term that's used a lot today, and it's a state of having all the things that you can see here. And I would say that in 2022, it is obviously just kind of put forward as something that is straightforwardly good, but is it? Or is it something that's worth having for its own sake? As Tina has already referenced, it is actually something that's been proven to be associated with better ways of thinking, more creative ways of approaching problems, and ultimately better solutions. And then when you think about representativeness or representation, you want to think about the different ways in which representation can be understood and how it can be applied. So Hannah Pitkin is actually a renowned political philosopher from the University of California, Berkeley, whose landmark work in 1967 was the concept of representation. And in it, she broke down the idea that representation is actually made up of three different concepts. One, the extent to which a group resembles a larger body. So you're thinking United Nations, or kind of in a more hokey way, a small world in Disneyland. Or the extent to which representation advocates for the interests of the masses, which you would imagine as kind of the court-appointed guardian for a ward of the state. And then there's the idea that representative advocates for the preferences of the masses, and that arguably be kind of our politicians, for example. And the question is, as we, or scientists, or clinicians who are committed to the advancement of science, where do we fall? Are we at the intersection of all three of those forms of representation? And do we have an obligation to be at that intersection? Many of you who grew up in the United States, and I recognize we have a very international group of people here, will recognize the lyrics of this song. So Woody Guthrie is kind of a folk hero in the United States. And many of us will have grown up in the US learning the lyrics to this classic folk song called This Land Is Your Land, This Land Is My Land. And these are the lyrics that I learned growing up. I am the child of immigrants, I'm an immigrant myself, and this is one of the songs that I learned in kindergarten that made me feel American. And it was the idea that if you reflected on the great beauty of the United States, that it would make you feel like a part of this great nation, even if you came from a very different place with different geography, different language, and different food. And yet, if you learned more about this actual song, you would learn that it was actually a song that was very much written in the vein of social justice and a cry for social justice. And in it, Woody Guthrie is not just writing about how beautiful America is, but also what America isn't for those who have the least in America at that time. And as you can see from the lyrics that are described later on in this song, America was not just a land that was definitely made for you and me, but he questioned whether it was a land that was made for all the people who lived within its borders. And again, it takes us back to the idea about representation. Who are we? What should we be? And in the world of science, to what extent we need to aspire to be representative of the people whose data we analyze and whose data we use. I also want to take some time to define two words that have been used a lot in 2020, 2022, and since 2020. Disparity is an observed intergroup difference in health screening and outcomes and or treatment, and it is different from a difference because the idea is that it is rooted in inequity. It is not simply a difference that comes about because of differences in preference or differences in baseline prevalence in a particular group. It is the idea that it is unequal and therefore it is ideally avoidable. In contrast, health equity is the idea that health should be distributed according to clinical need and that there should be equal opportunity for all individuals to access healthcare resources for the conditions they have. So you could think of the idea of disparity and equity as being flip sides of the same coin. But for you to understand or to seek the idea that equity is something we want and disparity is something to be avoided, we have to have a shared view of justice. And one of the things that's very much characterized the American climate over the past several years is that we don't have a common view of justice. And therefore, if we don't have at our center a common view of what should be guiding our approach to not only the way we run our country, but also the way we conduct our research, how can we all agree upon how we should be working towards providing an equitable approach to the gathering and collecting and ultimately use of data? Now, obviously in 2020, or arguably a little bit before, our world was changed forever by this viral force. And I want to take you all back to what the world looked like in late 2019, early 2020. Because at the time, COVID-19 was thought to be an important potential trigger for a revolution in how we think about healthcare. It was actually initially referred to as the Great Equalizer. People thought, you know what, if Tom Hanks can get COVID-19, then anyone can get COVID-19. We need to sit up and listen. This is not going to be like HIV. This is not going to be one of those conditions that ghettoizes people. It's going to be the Great Equalizer. And in fact, it proved to be the Great Revealer. We found over time, and not without too much time elapsing, that a disproportionate number of those who experienced significant morbidity and mortality from COVID-19 were non-white, racial and ethnic minorities, and we saw the same patterns occurring in all countries where there's significant diversity, that is the United States, Canada, and the United Kingdom, as well as France and other countries in Europe. In Chicago, for example, where African Americans make up 30% of the city, they had 50% of the infections and over 70% of the deaths. In New York City, Black and Latinx individuals, despite making up only 22 and 29% of the city, made up 28 and 34% of the deaths. A notable example is in Massachusetts, which is a very segregated state despite being in the northeast of the United States. In the city of Chelsea, which is 2/3 Latino, there is the highest rates of incidence of COVID-19 in the entire state. It's a town in which there are a lot of people working in factory jobs where the idea of social distancing was simply not possible at work or at home. And then finally, if the Navajo Nation in New Mexico had been considered a state, they would have had the highest rates of COVID-19 infection of any state in the country. And that was just what was reported. What we in fact know is that the way data was collected, even with knowing that we don't do a good job of collecting data, we did such a poor job with collecting data throughout this pandemic. 4 states throughout the pandemic never collected data with regard to race and ethnicity. And yes, you could argue that those states were Montana and
Nebraska and North Dakota and Wyoming. In addition, you could say, well, those states aren't that particularly diverse. But nonetheless, there were also several states that did not report cases by race and ethnicity. And those states included Alabama and Georgia and Louisiana and New York. These are not states where you could argue that the diversity of the population would justify absolving ourselves from collecting this important data. And as you will see from this important table below, the rates at which people were dying from COVID-19 disproportionately mapped out to underrepresented minorities, such that if you were from a black group, if you were from a Hispanic group, if you're Native American, if you were older, the likelihood of dying was much greater than if you were part of the general population. I mention this because as you listen to people from communities of color over the course of the COVID-19 pandemic, and you wondered why they weren't getting vaccinated, which continues to be the case, people expressed surprise given that we were seeing this disproportionate rate of both death and morbidity. You will also notice if you walk around in the United States that if you're seeing someone with a mask on, they are more likely to be a person of color. And that is, again, a gap in terms of who's wearing a mask, a gap in terms of who's getting vaccinated. And what you'll find is that a minority of Black and Hispanic individuals are receiving COVID-19 vaccines, and that reflects the fact that they also had a higher level of skepticism about vaccination in general. A higher portion of those individuals also have concerns about their children getting vaccinated. And these things reflect the fact that, frankly, they already have many relatives who've died of COVID-19. They have relatives who died of COVID-19 even after being vaccinated because they didn't get to the healthcare system in time. These are people who have a justifiable concern that American healthcare does not work for them. And why would they have those concerns? People often like to cite Tuskegee, which many of you will have heard about, as the reason why African Americans don't trust American healthcare. People like to refer to the past when they talk about racism in the US as if it's something that no longer exists. And what I want to argue is that the reason people don't trust healthcare in America is not because of how people who look like them were treated in the past, but how they're treated today. And I want to provide you this example. So in July of 2020, we all saw the publication of the first report of the phase 1 trial of what would prove to be the mRNA vaccine for COVID-19. It was a small cohort, 45 individuals, and what it showed ultimately was that if you received the vaccine, you saw a dose-dependent increase in antibody titers if you had after the first and after the second vaccination. And it was really, really encouraging because not only did we see that when you got a second dose, you got a higher level of neutralizing activity, but also that really there was nothing that ultimately was so concerning in terms of the side effects that we wouldn't proceed to phase 2. So this was exactly the news we were all hoping for. And it was occurring at basically the fastest rate that anyone could possibly imagine. This was a virus that was detected in December, I guess the winter of 2019, and here we were by the summer of 2020, looking possibly at the end of the horror movie. The cavalry had come. And yet, even though this particular trial was conducted by groups that were based in Seattle, Washington, and Cambridge, Massachusetts, 89% of the trial participants were white. And in this New England Journal of Medicine study, there was absolutely no mention of the strategy that was used to recruit patients or the yield by race. And so even as we knew at this point that Black and Latino populations were disproportionately being decimated by this vaccine, no attempt was actually made to target those groups for inclusion in these studies, or to report to them that they were trying to reach out to them in terms of recognizing disproportionate harm happening in those communities. And so again, when you ask people rather, why is it that certain groups don't feel like the healthcare system cares about them? It's not about how people were treated in the past, it's about how they're treated and prioritized today. It's about how they feel that their data is being valued and about how they are being valued. And their concerns that when their data is being collected, that it's not being done in their best interest. Ultimately, they are right to question who's at the table when decisions about research are being made, but when priorities are being made for who's asking the questions. for who's putting out the hypothesis, for who's providing the funding, for who's writing the RFP. And if we don't have diverse groups of people making those types of decisions, we're not going to have questions addressing the most underserved members of our society. I'd like to propose a framework for better science that honestly builds off of a lot of what was said by both Tina and Mike, who are obviously doing incredible work already in the field of data science and primary care. Everyone would like to agree, I think, that we should never let a good crisis go to waste. And the truth of the matter is that the COVID-19 pandemic did bring to the forefront, I think for many people, the idea that disparity for one group affects all of us. Because frankly, if one group suffers disproportionately from the side effects and the consequences of the COVID-19 pandemic, it means that everyone experiences longer delays in the ER. Everyone experiences longer delays to getting their orthopedic care, to getting their cardiac care, to having burnt out primary care physicians. No one is left with a better situation if one group is disproportionately affected. And so we, I think as a whole, have spent more time thinking about how equity can look, especially in the United States, where we know we don't have universal health care. And we spent more time thinking about how we can collect the data that would allow us to provide more equitable care. And this is a source of great interest to me and my research community and my research program. Again, this has often been seen as a reset moment in American healthcare, an opportunity to get things right. And two ways in which I think we can do this. One is more inclusive research design. So Tina already mentioned the NIH All of Us research program, which is obviously a great opportunity for us to get data from a diverse cohort of individuals using diverse measures, and we'll talk about that in a second. And then also more intentional data collection, including that is the collection of social determinants of health. So again, most of you in this room already know what All of Us is. It's this ambitious effort to collect a plethora of data. It's being led by the NIH, and the goal really is to collect data, DNA, PROs, patient-reported outcomes from over 1 million individuals living in the United States over the course of a decade to drive basically the development of inclusive precision medicine. And it also pivoted to collect COVID-19 data, so hopefully we can learn more about what the consequences of COVID-19 will be on people's long-term health over time. But there are obviously potential pitfalls there. One, there's the possibility of volunteer bias. That is, the kinds of people who choose to be in All of Us are those who frankly have the leisure and the trust to be involved in government-funded data, government-funded research. There's the concern about immigration, the health of undocumented residents. Are they going to choose to include themselves in this study, even as we know they represent a not small part of our population? And then, of course, we still need to think about the extent to which COVID-19, especially as the world, quote unquote, opens up, that many of our immunocompromised patients, including those of mine who are my cancer patients, have gotten more and more reclusive. Are those people going to be left behind? We're going to have different levels of missingness that are affected by who finds themselves increasingly segregated by the COVID-19 pandemic, and that is going to have unpredictable effects on the types of data that are being collected and who is included in that collection of data. With regards to social determinants of health, I just want to briefly describe what we're talking about here. So these reflect basically aspects of a person's life that don't seem straightforwardly connected to healthcare, but influence them in terms of the receipt and the consumption of healthcare. So this includes transportation, employment, access to food, access to drinking water, access to the ability to exercise, for example. And it's not quite the same as social need, which is different. Social determinants of health are kind of more fundamental, while social need is the idea that these are the consequences of your not having access to certain social determinants of health. And so there has been a lot more interest in them. It's become a priority for the US government as well as for a lot of researchers. There's actually a lot of concern that there's been a bit of, frankly, social equity tourism and research. That is, there's been a lot more kind of funding devoted towards this kind of research. And so a lot of people who never really did this kind of work before are now really interested in this kind of work because it's a source of funding. And so people who are really good at writing grants are getting this kind of funding, even though there are people who have been doing this kind of work in the shadows for a long time, but because they don't have the grantsmanship, they're not getting that funding. So again, thinking about who you're working with and how you can benefit them and partner with them. But the problem is we do a terrible job at collecting these data. So as difficult as it is in primary care, it's even worse in subspecialty care, such as cancer care, where I am. I devote an hour to seeing each of my new cancer patients, but let me tell you, by the time I've explained what is cancer, what is a cell, this is a metastases, this is a lymph node, I'm going to be taking out this and cutting this and reconstructing this, it's very hard to get down into, you know, what time do you pick up your kids from school and how are we going to coordinate that with your radiation treatment. It's also very interesting to see over the course of my training and my practice what tends to stick in the medical record and what tends to fade away, and for whom it sticks and for whom it doesn't. STIs stick. They stick for brown people. They stick for gay people. They don't stick for white people. It's also interesting to see how people don't put in updated phone numbers, updated need for language, updated need for interpreters, how comfortable we feel using family members. Again, it's really, really interesting how bad we are getting this data and how inconsistently it's documented. We have increasingly numbers of tools and Epic on our EMR that are devoted to these types of data collection that have 99% rates of missingness because we just don't have it as part of our patient flow. And so again, we do a terrible job about collecting it, and we do an even worse job about acting upon it. Because frankly, who has the time to take a break from their clinic room to call the nurse navigator, to call the social worker, and get them to clinic, especially in the COVID-19 era where hardly anyone's around anyway. So we need to think about these things. If we want to be responsible curators of this data, we need to think about the fact, as I mentioned, there's a lot of missingness and not all of it's at random. We need to think about the financial pressures and temporal pressures of collecting it. And we need to think about ways in which, how it's affected if we collect it outside of the medical system versus inside it. If we do it through the patient portal, we're privileging people who have access to computers, we're privileging people who have access to smartphones. How can we use low-tech forms of data collection to get to as many people as possible? How can we systematize it? How can we incorporate it into grants, into funding, as well as into grant-independent mechanisms that get to the people who most need it? That is the intractable, the unreachable people who, frankly, apps don't get to. When do we collect this data, and how iterative is the process of getting it? As I mentioned, some things stick, and they never get corrected. It is really, really hard to get the trust back of a patient who you keep asking every time you see them, have you got that gonorrhea cleared? Believe me, they will not give you any more information if that lingers in their medical record, because someone put it there and they never took it out. Who does this data belong to? Optum, which obviously is the partner from United Healthcare, from which people use a lot of data to get this information. More and more health systems are trying to partner with payers in order to try and market this data. But has anyone really engaged with patients to ask them how they feel about it? Yes, it's de-identified, but as more and more of our patients are becoming informed about this, they're not happy about it. And I don't know the extent to which we've done really any kind of true sunshine, let's have a conversation in public forum about this. I think that the time of reckoning is coming, and I think we need to be ready to have some good answers, because it's only going to take one millennial to put it on Twitter and say, did you know that there's a whole conference happening out there about this data science? They're using our data and no one invited us, just putting it out there. And so I just want to close by talking about two targets for how we can decrease disparity, increase diversity and representation in clinical data. One, in terms of improving how we obtain data on barriers to equitable care. As I mentioned, I think we need to do a combination of both high and low tech data options. One of the things that's really powerful is that even in many parts of the global south, text messaging is actually really, really able to be done, even with very, very simple phones. The other thing that can be used is that even if someone themselves doesn't have a computer or a smartphone, if you can get some type of low-tech instrumentation to a place that they can get to, you can use the kind of hub-spoke model. Get to a place where they trust, that's close to them, and then from there, use that as a place of data collection. That can be a way in which we can kind of work with trusted agents in the community in order to get information stored centrally. Patient-reported outcomes, which is a major part of the work that I do, is going to be really important. Right now, we need to work on making sure that those are in language and in culturally concordant and respectful ways that we can get to the heart what really matters to patients. And hopefully, collecting patient-reported outcomes can actually be then extrapolated to understand populations better. Behavioral economics, as I mentioned before, nudges, helping both clinicians and patients enter data that's more usable and putting it in a format that we can then use. You'd be surprised how many clinicians who are doing research, quote unquote, like to use color coding for the data that they put in. Have you ever tried to abstract data that's color coded? It obviously doesn't work very well. So again, we need to teach people how to put data in a way that we can actually use it. And then of course, learning health systems, EHR phenotyping, I think there's a possibility for us to do a better job of tracking data if we can put it in such a way that we can learn about the patients and kind of have bi-directional flow of teaching the health system and learning from it as well. We need to do enhanced navigation for those who are at risk, that is identifying patients through algorithms for people who need more data collected. We can't be doing kind of, boil the ocean, collect a lot of data on everybody. We simply don't have the bandwidth to do it. But if we can be very targeted at who needs enhanced data collection and enhanced navigation, we can then really funnel our resources on those individuals. And one potential ally in this process are community health workers who've been very effectively deployed in the primary care space to improve outcomes with regards to cardiovascular and diabetes health. I think there needs to be a breakdown of the silo between primary care and specialty care. I think it just needs to be care. I have a brother who is an internist and one is a family medicine doctor, and I think we all need to work together much more. And I'm hoping that this is a place in terms of data collection where we can do that. Really also then the community health workers can help us not only with data collection, but I think also with clinical trial engagement, and that's another form of being able to collect important data. Last thing I want to talk about alludes to, again, what Tina brought up, why we need diversity in healthcare and research. We can't just be thinking about the data as this thing that we do. We need to look like the people we want to learn about and the people we want to help. There are a lot of reasons listed here why we cannot afford to have a monolith within healthcare and research. And even though I've been doing kind of health services research for many years, only in the past few years have I really started to look at how and why we need to diversify the healthcare workforce. And I've been looking at that mainly from the perspective of surgery, because I'm a surgeon, and I've worked with a really dynamic, wonderful group of young residents and medical students where we've really seen that, frankly, and I'll go through this pretty quickly, if we look at medical schools where there are higher proportions of ethnic minorities amongst the surgical faculty, we are more likely to see both more women and more ethnic minorities amongst the medical students. And the reason we see that is because, frankly, in this day and age, in 2022, gender equity, relatively speaking, is the low-hanging fruit. What it is harder to get institutes to do is to really combat systematized racism in their institutions. If you can do that, the benefit for diversity across both gender and race will be greater. But it is harder work. That is, it is harder work, but the yield is greater, again, across multiple groups. And so, again, as we've seen, the benefit of diversity is not just for us to all feel better about ourselves. It really does lead to better questions and to better solutions. And I think it will ultimately lead to us being better data scientists, because the data we get will be more representative of the people we want to understand, the people we want to serve, and the science we want to create. So, with that, going back to my initial concepts of diversity and representativeness, I think ultimately we want to resemble the larger body of people who understand. We want to advocate for their interests, and we want to advocate for their preferences. I think we very much want to be at the intersection of those three forms of representation. I hope that after this talk you would agree with me. So, thank you.
Thank you. In your studies of health disparities and health equity, do you consider income inequality as an explicit variable?
Yes, so income inequality is income is very difficult to capture at an individual level because it's very poorly recorded. So in the medical record, often the best measure of income inequality or socioeconomic status is frankly insurance status, which is very poor. We can know if someone's a Medicaid, Medicare recipient, we can tell whether they're dual eligible, we can tell whether they have private insurance, what have you, but we can't usually tell what bracket they belong to. We can also see what education level they've received. Now, on another side, as a leader in the health system, I can see, because of development, what the potential contributions are of my patients to the larger mission of the health system. And that is something that I know because of my position that I obviously would never use in research. It is interesting, but again, something I can't apply. It is a real challenge. It means that we can only really use area level information, as we can take the median income by zip code level, typically based on tumor registry data. That's what's typically used when we're looking at tumor registry or looking at things like the National Cancer Database in terms of applying a median income. The other possibility is you can use things like the Area Deprivation Index, which is based off of responses to the American Community Survey. And that is something that's increasingly being used to understand, again, area level, block level, levels of deprivation and therefore income. But the truth of the matter is, even income is a very imprecise measure of socioeconomic status. We increasingly think that wealth is a better measure of
wealth,
someone's
yes.
status.
I think actually
and that
that's
is
what
even,
I kept
and
in
that
mind.
is even harder to really capture. So again, we don't know what we don't know. We do know that the wealth gap between Black and white Americans is vast, and that is largely related to the systemic inequalities that descend from slavery and that continue today.
Sure, but I also think that wealth inequality is a problem that affects all races, all ethnicities, and all statuses, including the immigrant status.
Correct. As an immigrant and a Black person, I'm very much there with you. When my parents came,
something
yeah, in 1980,
might be worth to look at explicitly.
If you can find us the data source, I will partner with you. And that's one of the things that was their New England Journal of Medicine editorial just this past couple of months, actually, by Eugenia South, specifically talking about how we can't fix disparities until we address the wealth gap. But then how do we get the data for it? That's one of the challenges. How do we get the data? And so I think one of our challenges as data scientists is partnering, frankly, with qualitative researchers. We need to work with people who know how to ask these questions, how to develop the samples, how to write the questions, and then how to analyze the data once we actually have it. So again, that's an opportunity to get that information more completely. Thank you.
Great answer. Thank you.
Let's go over here.
Hi, I just had a question about, in order to get better data or to record data and share the data for research, and you were talking about SMS messages and getting patients involved. Like during COVID, telehealth became sort of a standard. At Veterans Affairs in the rural areas, they set up private rooms at Walmart's pharmacies so that they had good internet connection, they had good video connection. So to your point about gathering data in rural areas where they don't have the technology or to a place where they feel safe, if moving forward, if these are the ways to collect data, does then grant applications have to be written differently in order to accommodate these new forms of, you don't have to travel to Bethesda, Maryland in order to be part of a research study. You don't have to show up twice. You don't have to take time off of work. Does that mean that the grant has to be written differently to accommodate a different way to get a better sample size?
Yes, is the short answer. Actually, in my previous institution, I was the director of the breast clinic at a VA. And one of the things that I started there was a support group for women with breast cancer, for veterans with breast cancer. And during the pandemic, we moved to we went to a virtual support group. And for many of my patients in that support group, they said that that monthly group was their lifeline. They often spoke to no one for a month. They were having their groceries being delivered. I mean, it still gives me chills to think about that. But it was literally the one time they really connected with anyone over the course of a month. And we also started a grant specifically working with some of the Native American tribes in North Carolina, where we were working with meeting houses to serve as sources of telehealth because we couldn't guarantee that people at their homes had the ability to access telehealth. And we did partner, we were actually applying for grants with private foundations because we knew that that would actually be, frankly, a more nimble way to get the funding than working with the federal government. I shouldn't probably say that here. But that's all to say is that I do think that I think we will need to be more creative in terms of whom we partner with, in terms of what is a site of partnership, so a community site. We need to enable those sites to be able to partner in writing those grants. You know, as I was mentioning before, equity is becoming a tourism site for funding. And so some of the places that can really do amazing work, they don't have the skills or the experience to write these grants. We need to put people there to help them learn how to do it, and maybe just to do it for them with their input. That would really be the altruism of good science. I really do think so, is to say, we care enough about this population, about this outcome, that we're gonna work with you to make this happen. And I think it does mean thinking creatively about who a partner looks like and what an advocate looks like, because the truth of the matter is the advocates are disproportionately white, well-educated, have leisure, don't work outside the home, and are retired.
Thank you.
Thanks.
Thanks, Doug. That's a good segue. My question, first of all, the idea of social equity tourism and research is problematic because it says money's going to go in and it's going to tail off, right? And so, and short of turning over these bodies that from the RFP level all the way down to the researcher into groups that look a lot more like America looks like in some sense. How do we start the positive feedback loop? And I think you're giving these suggestions such that there's an increase in funding because it's benefiting people, and that is the value that we hold and that we're after. In particular, what project I'm involved with does return of results to patients. And those are a little bit also problematic because you can't necessarily say in a clinical trial that, hey, if we give you these things, your doc will be able to cure you. But from the standpoint of creating a relationship with the participants and their providers and gaining trust, do you think return of results is a way to sort of turn over that positive feedback, or is it not as simple? I'm sure it's not as simple.
No, I do think it's a first step. And I was thinking about the fact that so many of you in this room will also apply for PCORI grants. I certainly have, and as many of you will know, one of the requirements for PCORI, more stringently than many other federal funding agencies, is how are you going to get this data back into the hands of the people who were included in the study? And I wonder but I often feel like that is like the last thing people are working on 5 days before that grant is going in. Like, you're hustling, you're kind of throwing it together, you put something together about how you're going to publish it, you're going to get them some kind of raw data, you're going to get it to the community advisory board that a lot of us put together, real talk, right? We're amongst friends. And I actually wonder if there needs to be a more stringent requirement, that is actually what you lead with when you talk to a program officer, right? As of now, if you're talking to a program officer, the first thing you present are your specific aims. You present your specific aims, you present who your team is going to be. You want to convince this program officer you can get the work done, that the work seems doable, right? But if instead, program officer said, what I care about is that when this data is done, when this analysis is done, you actually are going to get it back to the people who this affects. If the program officers, because they have so much power, as we all know, if they were the ones who set the tone and said, if you can't prove to me this is really going to happen, then you're not going to get the money, that would really change how much more this got back to people. That's my suspicion. But
just an encouraging fact is that at the end of January, all the program officers are going to insist that the data be available, that whatever data they create, there's a data sharing mandate. And that can play directly, I think, into sharing that data in some sense with the participants of the study. And so we may be on the cusp of being able to effect that idea.
That's really good. I'll keep that in mind in the study section
at
next month when reviewing applications. Thank you.
Thanks.
Tina.
Thank you so much. That was a wonderful talk, and I really loved it. I want to ask you, so you talked about all of us. I talked about all of us. We've been trying to look at it, and so it's really seen as this data set that's going to bring all of these diverse populations into our scientific realm, and we can use this data. But in reality, while recruitment is looking looking really good, the response rate of underrepresented populations is really minimal. And so I'd like to hear your thoughts on, is our approach just giving them these surveys the wrong way to go about it? Are there other opportunities to collect this information? Because really some of the survey data in the Olivis research is missing for, we're looking at Hispanics, for example, 90% of them are not answering these survey questions. So it's a great attempt, but what are your thoughts on increasing the response rate for some of these really important questions we need to learn about?
So, I think we often think that once a survey is in the hands of an individual that we've done most of the work, but as you just said, often it's so interesting, and I'm not a psychometrician, but it's so interesting, the psychology behind what people choose to answer and not answer, right? That, oh, that looks like too much work, I'm gonna skip, I'm not. So, I think part of it is, one, how, and again, you don't want to change the questions midstream, obviously, because that will affect the way you can analyze it. But whatever can be done to keep people engaged in the moment that it's open, because that's the moment of capture, right? That you have the person there, whether it's at their computer or whether they're sitting there, what is it that makes them say, hey, we really need you to answer this. When you're answering this, it means that, someone who's just like you can benefit, So I think that that's it. And again, I'm not a psychometrician, but I think that's really the question is, you've overcome, the activation energy of their opening the survey. So then how do you get them to proceed? And I think that's really something that I would engage a psychometrician with, because I think about it myself, the questions I skip and the ones that I answer. And the ones I answer tend to be ones that I think will be cathartic for me to respond to. And so that might be what you need to figure out, what will provide catharsis.
Yeah, and then I just think, is there an opportunity to think about, how we're disseminating it, where we're disseminating it. You look at the barbershop studies and these other studies that are so successful, yet when we're doing the Olivis cohort,
So are you saying it's 90% missing once they've opened it, or that they're not opening it?
They're opening it, but they're not filling it out.
Right. So then that's two different things.
It's a trust issue.
Yeah. And then there's the question of how can you make it very clear that your data will not hurt you? Because, again, even if, something again a lot of us in this room know, and I say this as an immigrant myself, what people who have been born here don't realize that many immigrants, I would say most immigrants, go through a hairy period at some point with INS. At some point, things were not quite right. Almost everyone, because INS is a hot mess, and it's always been a hot mess. And so everyone, if there's ever a question or something that makes you feel the least bit unsafe, even if you have legal status, you will not answer that question because you can't be sure that this prized thing, that blue passport, won't be taken away. So I think that's something else that needs to be looked at, is how can people be reassured that they will not be in any way threatened? Because honestly, our country's not done a good job making people feel safe in that way.
Last question.
Anand Marbushi, Emory University. Thank you for that fascinating talk. I had a specific question, given your background in breast cancer as a breast surgeon. I'm sure you're aware of the paper that came out in JAMA Oncology last year looking at Oncotype DX, showing that Oncotype DX actually performed poorly in black women. This tethers back to a question I think that was asked a couple of talks ago with respect to creating population-specific AI models. Just wonder your thoughts on what you thought about creating risk calculators or AI-based models that were more specific to particular populations.
That's a really great question. We have a paper coming out, an opinion piece where we're recommending earlier risk assessment for black women with regards to mammogram screening. Not so much that women need to start mammograms earlier, but that there should be an assessment, frankly in your 30s, as to whether you might be a high-risk person, because we know that there's less, for instance, genetic information data amongst black women. Fewer black women know whether they have a family history of BRCA mutation carrier, whether they have a family history of even breast cancer. And so they're more likely to be caught off guard and be a de novo mutation carrier at the time of a breast cancer diagnosis. And they're more likely to be diagnosed before the age of 40 when mammography screening typically is recommended to begin. So with regards to race-based recommendations, I want to begin with what we all know is that race is a social construct. That does not mean, obviously, that there isn't, that race can't be a very imperfect proxy for genetic ancestry. And I think that's kind of where we need to think a bit more creatively. You know, the truth of the matter is, as Tina pointed out, the mixed race category is the fastest growing category in the United States. And we know from studies done by Lisa Newman, now at Weill Cornell, that what puts people at risk for different, different types of, more aggressive types of breast cancer has more to do kind of with the, what do we call it, the genetic anthropology of their heredity, right? That depending on where their genes came from. And so there are people who identify as African American for whom their genetic ancestry does not reflect what they check on a box. And there are people who identify as white for whom that is also the case. But that is not something people like to say in good company. So that's all to say is that I think we need to hopefully get to a more nuanced understanding of what genetic ancestry looks like. Until then, race is a highly imperfect proxy. And I think it means that we need to counsel our patients from underrepresented groups and say, look, you, people who look like you and people who identify as you, even if they don't look like you, are not well represented in this data. As a result, we need to take certain precautions in terms of what we recommend and the care with which we provide recommendations for how we screen you and how we treat you. And so I think that's all we can do in the interim. At the very least, we do need to incorporate race into some of our risk calculators, again, with regards to providing people informed information about the decisions they make, rather than saying you absolutely need chemotherapy, you absolutely do not. We need to provide context. Thanks.
Great. One more round of applause for our speaker, please. So I'm going to pass it over to Eric. We're going to move into a session on the stage. We're bringing out some chairs for all of the different speakers from today. Eric, do you want to say anything? I do. Here you go.
All right, we're going to do a little bit of housekeeping while they set up the chairs. The breakout sessions are going to start 15 minutes after the panel discussion ends. The rooms for the breakout sessions, there will be signs back there, but the rooms, just for reference, are rooms 123, rooms 218, and rooms 223. There'll be signs out there. We're talking about all topics in all rooms, and again, we have our cards that you helped fill out at lunch that we'll be incorporating into those breakout sessions as well. Another thing to mention is after the panel ends, all the presenters are going to gather on the steps outside this hall for a group photo. So if you were presenting last night, today, tomorrow, after the panel ends, we'll gather out there for a photo. With that, I'm also going to say thank you to Amber for doing a tremendous job doing the moderating of the session and the presenters. And we're going to give her a break, and we're not going to make her moderate the panel. She gets to be a panelist. So at this particular point, let's have our presenters from today come up on the stage, and we can have our panel discussion. So while the panelists are coming up, I do be thinking about the questions that you would like to ask the panelists. I know that we've had a really robust Q&A session as the presenters were speaking at the end and things of that nature, but this is an opportunity to really ask the panelists collectively some of these questions and perhaps get different insights and perspectives about some of the challenges that we may have heard. I had a chance to read through some of the questions that were posed, and there's some very interesting questions here that will feed into the panel as well. So as soon as all of our panelists are up there and assembled, we will start the Q&A. I'm waiting for Amber. All right, so while we're waiting to fill out the panelists, one of the questions I want to ask, this is a show of hands. How many of you knew of Hood College before you heard of this symposium? All right, so how many of you hadn't heard of Hood College before this symposium? All right, good. Hood College, we've done our job. We've gotten more visibility for you through this symposium at that point. With regards to the symposium and the presentations that we've had so far, how many people have found it valuable and insightful? All right. That's a good sign, because then we have that. And we may end up starting, I'm not sure, Amber might be taking a break, but we'll start some of the discussions, and when Amber's ready, she can come down and join us. All right, so I'm going to ask some questions. I'm going to ask one, and then I'm going to go out to all of you and see if you have a question that you would ask of the panelists. I like this one. This is one that was asked at the tables. So how do we go about building the bridges across the interdisciplinary groups to generate the stronger understanding and coordinated efforts? Panelists, how do we do this? The mics are there, the mics are hot, so somebody can pick one up and start answering.
Can I ask what's the definition of interdisciplinary groups?
That is a good question. I'm not sure who offered that question to us, but I think you can take and define that as you see fit, because you may have different perspectives from each other about what that means.
Yes, that was my question.
Well, why don't you give us a definition of what you think it is, and then how do we actually build those?
So in my mind, that interdisciplinary is the broadest sense of the word. I think that there are groups within groups as well as groups outside of groups, and I think that we kind of need to break down all of those walls. I think across domains, we don't even need to just stay within healthcare. I think the data challenge is universal. I think the bias questions are universal, so I would say that as broad as we can make it, and as inclusive over time.
I'd maybe say, think about inviting people. I was surprised to get the invitation to come here. I think it's great. I've heard lots of interesting things. I think maybe think outside your usual box. We've had people on some of my research teams who are very medically focused, but when you have a team that includes a sociologist or anthropologist and patients, as well as the clinicians and the data scientists, it gets very interesting.
So I would say, well, two things. First of all, just do it. I mean, and I mean, because I don't think there's a one-size-fits-all approach, but the benefit of putting people with multiple disciplines together just continue, it's super clear. But you have to be patient. I mean, they speak all different languages, they come in with different approaches, and the only other advice I would give is for a project that is a multidisciplinary project, to have a very clear goal, that all the different people coming in understand what the goal is. And then they may approach it all differently, but at least they're all aiming for the same goal. And then eventually you build that trust in a successful team, and you get to work together. It takes a while, but you have to just start. I mean, it's never pretty when it starts.
But you have to work together to make that goal. That's the thing, because you yourself can't figure out what that goal is. If you're going to do truly interdisciplinary work, you need to be able to extract that from a group of people and then align those people towards that goal, because the sum of the parts is greater than the whole, right? So and those are the kinds of conversations that you have to have. And if you find yourself in a room where you know everything that's going on and everything's really comfortable, then you're probably in the wrong room and you should do something else, because you should be uncomfortable.
I would also recommend,
I think,
sorry if you can hear me. I would also recommend strategic proselytization. By that I mean finding out ways in which you can have people who are like-minded in spaces where you yourself cannot go. So a good example of that is, as I mentioned, there are a lot of people who care about the research you're doing, but who just don't know the importance of how to enter data appropriately. Like, you'd be just amazed. So for me, my little step of trying to just convince my fellow oncologists to put in staging data in the actual staging form, rather than putting it free text in their note, is my little attempt
to help them contribute to systematized data entry. That's my one little thing. And fortunately, I have an accreditation board on my side. I tell them, if we can hit 80%, it means that we're more likely to be accredited by this particular organization. So again, it's one of those things where they don't appreciate it. They just think it's a form that they're not used to using. But if I can do that, hopefully it makes it a little bit easier for that data to be abstracted. So again, finding ways in which to appeal to people where they're at, because the average person may not necessarily see why you think that's important.
Yeah, and I'll just build on that to say, when you're building these interdisciplinary teams, everyone has to feel valued. Their responses, their input, their suggestions are going to be different. And they have to feel that those suggestions are valued. And so, and it's hard because we're all professionals. There's a lot of egos at the table. And so when we're building these teams, we have to have equal opportunity to listen and to, that's it, to listen to these ideas and understand how they can integrate with your own ideas and frameworks of thinking. So I think it's really about being more open and adding value.
Okay. Any last comments?
I'll add one more thing. In my experience, it's skills don't work with other skills. It's people who work with other people. So having avenues where you have like-minded individuals come together and genuinely connect on a certain topic, that would help foster a collaboration without the sense of competition. I think that's what we need to bring to help interdisciplinary connections happen.
Okay, very good. Let's go out to questions. If you would go to the mic, that would be fantastic.
I have a question on what can we do. A lot of you mentioned the importance of data diversity and the representation. What can we do to encourage and increase the workforce diversity?
I'll start with this one. This is something that was discussed at our table during lunch. And we were talking about bringing in AI education at an early time point during the course of our own education. So start thinking about undergrad or potentially even high school, where you start to teach statistics at an early time point so that people understand the concept of study designs. How do you analyze data? What does it mean when your distributions look this way versus that way, which are all the foundational models for any kind of AI-based analytics. And then supplement that with a course on data science or real-world skills like data cleaning, harmonization. What does it mean to have a complete versus incomplete data set? And bringing those aspects into our training and education at an early time point, that will eventually, over time, help build a strong workforce.
So it's interesting. I would say that there's been a lot of efforts to encourage STEM education at the early ages, kindergarten, middle school. My kids joke that they now call STEM STEAM, which is science, technology, engineering, arts, math. They're like, Mom, that's everything. I'm like, I know. While I think that that's important, I will say that there is growing evidence that, frankly, we're not doing a bad job of exposing children and high school students to those things, but there is the real issue of the frustrations and the bias that fully trained individuals are experiencing once they hit the workforce or postdoctoral training. We know that people of color are disproportionately likely to be discriminated against as postdocs, as residents, as fellows, as junior faculty. They're just likely to make tenure. They're just likely to have their ideas actually put into the public sphere, despite the fact that there is actually, as was mentioned last night, that often the theses and dissertations that are put forward reflect often greater creativity and novelty. So we can't look away from the fact that even when we get people to the point where they're ready to launch, we clip their wings. We, as a society, clip their wings. And part of it's a hidden curriculum. It's part of it's that you're not taught, maybe, the way in which to hobnob, to get invited to the boss's boat, to make it to the golf course. Part of it is that you are judged for the way you dress and the way you talk and the things you're willing to say about your private life that you may not be willing to share. And people therefore think you're reserved or that you're not willing to engage with people. So I really think that can't be underestimated. I've seen it too often, and I have too many residents and medical students crying in my office about this. It's very real. So think hard. When you hear about a woman or a person of color you're being told that they're difficult, I want you to think really hard about why that might be.
And I'll add to that, and I think that it's true that do you not get invited to the boss's parties, et cetera, but it also happens on social media. So there have been reports recently saying that, the minority or female posts are much less likely to be forwarded or liked or supported, and so it's not only in the true in-person social situation, it's through society. In terms of what can we do that we can proactively individually do, it is that sponsorship, it's the advocacy that we can actually take action to provide people opportunities, provide that voice, and making sure that the ideas are acknowledged and attributed to the person who's actually come up with the ideas, and making sure that that is attributed. A great example that I had from a mentor of mine was that when you're in a group meeting and someone says an idea and it's acknowledged that it's a good idea, he went and acknowledged that person by name immediately and said that's a great idea, and made sure that the room recognized that person had initially attributed. And when someone else comes in and echoes, which is a common example that's been provided, that then someone else says it, and 2 minutes later, and then the next person's been attributed, because that's been acknowledged. And then when that other person echoes and says, just as so-and-so said, I totally agree, that's a great idea. And so it's not devaluing that validation, but it's actually raising up the idea. And so that's just something that was a great example that I saw demonstrated in meetings that I thought worked really effectively.
The other thing I will say is, don't be afraid to hold the minority, whether that's gender minority or racial and ethnic minority, trainees or junior people in your group to high standards. Sometimes what ends up happening is that people are afraid to tell you what you need to succeed because they don't want to hurt your feelings. No, truly, this is a huge problem. And so when it comes time to be actually assessed by certain objective metrics and people fall short, it's because no one told them that they weren't meeting them. The term that's been used is the bigotry of low expectations. And it's very real. And it's something that comes about from people being too nice to be honest, and not frankly expecting people to do as well as you think a white person or a man can. So again, I want to encourage people to realize that yes, there's a leaky pipeline, but even when the pipeline arrives with a relatively full stream, we then let people off towards the end. And that's often after many years of time put in.
And I'll maybe just finish. One of my other roles as a department head is, hiring and mentoring new faculty, and I think that's a critical juncture. And I think the most important thing that those who are in leadership can do, like myself, is to try and provide people the space and mentoring to really get established, because so many people will get dragged into administrative or representing their underrepresented group or those sorts of activities that won't help them fully get their scientific career off the ground. And the more we can do that, because then we have a diverse faculty who can, as to your slide, help lift up everybody.
We call that the diversity tax, right? And so, and I tell my students and my mentees, they're like, oh, I was invited to be on this committee and this committee. I'm like, how does it serve you? How does it help you in your goals? And what's you have to be careful, because you can fill your time being on these committees, and then in the end you realize, well, I'm there to fill a role that isn't beneficial to me, right? I'm there to fill a role that is to ensure the committee is diverse, has a woman on board, has a minority, so whatever it is. And so I always tell my students to be thoughtful about these invitations they get, because it is a true tax.
And that's not to say that, most of us want to be on these committees because we care about the development of these groups. It's a double-edged sword. It's like you don't want, it's like, why didn't you ask me? It's like, I want to be contributing to these conversations. But as I showed on my slide, those of us who are from underrepresented groups, especially if we, wear those identities in duplicate or triplicate, we're asked to do a lot of that work. So for example, at my previous institution, I was asked to mentor the first transgender resident actually in the whole institution, just because that person actually had mentioned to my chair that they had connected with me during the residency process. And I had to pull that individual aside early on and say, they're going to want to put you on every pamphlet in this institution. Do not do it. Your job is to learn and to be here and to survive residency, because not everyone does. We just had suicide prevention awareness this past month. And there's a lot of evidence, especially in surgery, frankly, that if you are from an underrepresented group, your likelihood of committing suicide is much higher than majority individuals. So again, that's all to say is that the burden is very real. It also can be a joy, being able to represent your groups and to advance other people. But again, in terms of creating a diverse workforce, we need to think about the people who we're entrusting to that, and we need to have some of that work taken on by people in the majority. You know, it needs to be prioritized for people who are not in the minority, who want it to be important to and to do the work. So.
All right. Any last thoughts before we go out to Michael for the next question? All right.
I want to turn back to the issue of interdisciplinary efforts. You summarized it pretty much that bringing together people with a lot of different skills is very important to tackle a problem. And then I believe you also summarized the fact that it's good to have them all working towards a common goal. But I think there's another level of interdisciplinary that you need to address. And that is, if you take the problem and you look at the fact that, say you take breast cancer, and you look at the fact that the physician will tell you certain issues are the challenges, the patient will tell you that there are different issues, the drug developer will have another set of issues, and the diagnostics developer is looking at it from another perspective, and the payer is looking at it from a fifth perspective. That's another kind of interdisciplinary effort that I think needs to be incorporated when you start to bring the teams together, because they may see that they are addressing different parts of that and being able to do it effectively, but that gives them the goal and gives them sort of a message. I wonder what you think about that addition.
I feel obligated to speak as a breast surgical oncologist, I guess. You know, I feel like breast cancer is actually a perfect analogy for the kind of multi-stream approach to problem solving that you're describing, because we increasingly realize that breast cancer is a heterogeneous entity that happens to share an anatomical home, you know, as we understand the kind of, you know, difference in subtype and even the differences within subtypes. And so I agree that I think sometimes it might be that, frankly, our grants are going to look different, right, as we try increasingly move towards team science, that we're not, that our, you know, that our, I think what I've found, for instance, as we start writing U grants, for example, and these P50 grants, is that each aim feels more like a very kind of different type of thing, that the kind of unifying goal for the project is often very broad, because really we're coming at it from such different types of methodological approaches. And so, you know, in terms of ultimately what our bigger goal is, making care better or understanding a disease better and tackling it better, yeah, I agree. We need to come at it from different angles. And then the question is, how do we get us all to the same place? I think that's kind of what we're here to figure out. I mean, one thing I figured is working really well is recognizing the different constraints everyone has on their time and energy. One thing that I always have to tell my PhD colleagues is that, you know, there are going to be periods of time where I fall into a black hole of clinical busyness, and so I will try really, really hard to be available to you during these academic periods, but then if I have to do, you know, just a lot of clinical work for a while, I won't be available, so I really appreciate it if your postdoc can get me this data by this time. So that is, again, my way of signaling, look, I'm here for you, but here are my limitations. And they'll have limitations for me too, in terms of this is a hard, fast rule that has to be done. So part of it's learning each other's language and learning the confines of each other's world and how we can work together.
I think this is where, you know, events like this or organizations can use their convening function to bring people together to set those big goals. Because I think if you're going to start to bring together those broad groups of people who might all have their own individual ideas about priorities, if you haven't had a big tent discussion first about what are those big overarching goals, And then you can bring the teams together and maybe with some of those same people. But I think that's a really important role. And it speaks to the balance between kind of strategic research investments in those big goals versus pure discovery research. And we need both. But I think the balance and who gets to set the strategic priorities is what's different. So a broader tent for setting the strategic priorities, and then bring the groups of researchers together to say who's interested in working on this and getting it off the ground.
Any other thoughts? Go ahead.
To add to that, I do think it's important to bring all these different groups of researchers to work together. And you're right that each will have their own priorities. And I'd say it's the same for the funding institutions as well, the sponsors. So it might be time to think about bringing multiple sponsors together who would each fund their respective set of priorities toward that common goal.
All right.
I have a question, hopefully it ties together a couple different threads. It's about getting higher fidelity and better data and incenting the patients, right? We talked about, for example, a certain population had a less 90% no response rate on a particular survey. And what was said was kind of, well, we need to make sure that they're not worried about how their data is going to be misused, right? But the flip side of that is what can they get from their data, right? There's all these, outside of healthcare and machine learning, different mathematical models to compensate people for sharing their data, particularly in social media or retail, right? Right now it's all free and they're just, they're the product, right? So how can we compensate people for their data so that it's more accurate and that we can use it? How can we do that in the healthcare market? Like was also mentioned, getting back to the patients with the results eventually, or having open source data sets for sure. That'd be great, but how do we create this healthcare data market, if you will, that incents patients, now and going into the future, as we need more genomic data, more DNA to actually unlock these insights, to get them involved and incented to join and share the data so that we can use it and get that more representative population without putting more strain on us to clean up and press for more data.
So, I can talk about some of the things we're doing to that. So I think there's a great opportunity to partner with industry, with other companies that are collecting these data. So for example, we've done, not my group in particular, but at Stanford, where they partnered with Oncotype DX to get those genetic mutations to see if we can match them with our EHRs. We're working with Fitbit to see, can we start matching, bringing in data. So it's really about thinking about the diversity of data we have and where we can start pulling in all of these other streams of data to augment where we have gaps. We also use social media a lot to pull, what are patients saying about a particular drug or a particular treatment or things like that. So I think there's a lot of data sources that are not fully used right now that we can pull into our healthcare domain. The problem is, as we've mentioned earlier, we do a lot of our work in silo, right? We look only at EHRs, only at images, only at genomics. And so the more we expand those data sources and expand our ability to combine those multimodal data types of data modalities, I think the more we can get at augmenting the data that we have and expanding on what we know.
So I contribute a lot to open source data. I'm on that train. I support it. But boy, I do think sometimes that we might be on the wrong side of history. We have the Golden State Killer that was caught through genetic genealogy. Does that not scare other people? That scares me a little bit. That if I, get sequenced through something, is there even a consent process that can happen where people can really understand what we can do with their genomic data if they give it to us? I'm not even convinced you can really have informed consent in that process. So, yeah, I don't know. I worry sometimes. I worry.
I'll add to that. In terms of the understanding and true informed consent, and the definition of informed consent, that gets very blurry. The second piece is that from a regulatory standpoint, the rules are constantly changing. And so I think until we can actually establish some sort of dynamic consenting process where people can actively and know what that actually means, GDPR really turned the world upside down in many different ways, where you need to take out retrospective as well as stop collecting prospective data. That's an extreme, but perhaps some other forms or models of dynamic consenting is probably where we need to go. The second piece around this is that yes, open source data does scare me as well. And the reality is that if you have open source data that's completely anonymized on a single set of data within a silo, it's very difficult to go and say you're going to be able to identify that patient if you truly anonymize that data set. As we start to build in richer and richer contextual data and tie it all together, no matter how much you've said you've de-identified or anonymized each of those individual sources, you can start piecing together that story if you really want to, and it becomes identifiable. And so that consenting process is a very different level of risk and information that you're giving the person when they actually consent. And I think all those moving parts have not really been resolved at this point, and that's where the challenge really lies.
I guess I have two comments. One, more concrete, and one more specious. The concrete one is Kemi Dahl is a gynecologic oncologist at University of Washington who specifically studies endometrial cancer and disparities in endometrial cancer amongst Black women. And she'll just tell you, show them the money. She hires women to be part of her research team. Just pay people. The truth of the matter is patient advocates for the most part are volunteers. And even when we create these community advisory boards, it's often on a consultancy fee. You give someone $1,000, you pay for an hourly fee, but what if you employed them? What if you employed survivors or relatives of and caregivers and patients with cancer as members of your research team? Given that, again, in America, wish we were Canada, people are entitled to employer-based healthcare, and some of my patients lose their healthcare while they're getting cancer treatment, right? So why don't we pay them? So show them money. That's one thing. Is if we had patients at the table, part of this, that'd be one thing. The more specious comment is, I honestly mourn the innumeracy and illiteracy of the American public. I mean, I think that when we talk about risk, we need to just recognize that the average person just has no idea what risk means. You cannot explain to them that each time someone has a baby, it's a 50-50 chance they're gonna have a boy or girl. They don't know. That is the reality. And so I think part of it is we need to start thinking about, in our schools, how are we teaching stats? I am struck by the fact that even young children are not being given a basic understanding of what risk and what statistics means. And so that's just my specious comment, that I am struck by that very fact, is that we don't know how to teach and explain that to adults because we're not teaching it to children.
Thanks for the answers. I think keeping even patients that have been cleared to come back, employment, something like that'll pay a lot of dividends feeding back into the team. So I think that's a great answer. Thanks.
So I want to,
I was just going to say because this came to the question before, the data governance side is so important too. So I think a part of the answer is if you've got effective governance for sensitive data, in Canada we have for Indigenous data, for example, there's a set framework that has to be followed for using the data, and it means that no one can use the identifier for Indigenous identity without the consent and review and approval of an appropriate oversight group that's there with the thing. And people know that before they contribute their data. And before that happened, we had our Canadian Community Health Survey. First Nations on Reserve wouldn't participate. So they created their own side survey, same questions, going along, linkable, can also be shared, but then now the community knows their leadership was supportive of them completing the survey. And so, it's hard to do for every single community. You don't always have the right people, but effort in that area is probably where you need to go.
So I think that really highlights the importance of trust, which is, as has been pointed out, is lacking in the United States and a great many communities, which makes this very complicated. I'm a little, I don't know, I'm a little queasy about the notion of just paying for all the money, but maybe that's just me being old-fashioned. I mean, maybe that's the simple solution, right? So this is America after all. Show people the money. But the only thing I was gonna agree with wholeheartedly was the notion of people's misunderstanding of the very notion of risk. And I believe Daniel Kahneman won a Nobel Prize basically pointing out how poorly people understand risk. And the thing that was, if you ever read his book, I think he has several, the book Thinking Fast and Slow, which came out right around that time, he highlights it's not just the relative uneducated American, which is a sad statement, who doesn't understand risk, but he gave test after test to his own students in his graduate statistical classes, and they didn't understand risk. So I think humans don't understand risk well, I think is a fair statement.
All right, Roxanne.
Hi guys. So since this symposium was rescheduled, AI ethics and bias has really grown and become much more nuanced as a topic in this field. I think we've gone from, AI is going to solve all these bias problems to kind of, and such as what Amber said, like we don't really have a perfect data set. Maybe we can't get there. And so I'm curious on how your thinking as research has evolved in this area with these data, and also just speaking from a purely funder perspective, other than giving you guys blank checks, how can NCI and other funders help support kind of moving this really fast emerging area forward?
Change review criteria so that when I'm on panel, I can cite the review criteria in my review, and then it's not left up to program officers because it's written into, well, to some degree it still is, but it's actually written into how we review grants and how we can put grants forward.
Anyone else?
Yeah, well, so Roxanne's my program officer, so I love Roxanne. Full disclosure. But I mean, I think there's a lot of opportunities to really think about what are the areas that we're talking about here and having the appropriate mechanisms to move forward. I mean, unfortunately, for most grant mechanisms, you have the idea, you write the proposal, it goes under review. We're talking 3 years down the line. And when you're writing that, so you're writing something that's going to happen 5 years down the line, so there's no way we can project, what, certainly in this field, what technology is going to be up to date, et cetera. So I think if there's a way to think about other mechanisms that are more quickly attainable, so some of these seed fundings, and is it possible to have another mechanism that brings that quicker around? Because really, we're all doing this cutting edge research, and 3 years from now, it's not cutting edge anymore. Right, and so that's the problem that I see. We still do, of course, our regular grants, but there are opportunities.
Go ahead.
Oh, just one quick comment about how it's changed my thinking is a much higher level of awareness of. I mean, I think as one of the speakers said, I can't say I remember who now, but AI itself is not biased any more than calculus is biased, right? I mean, it's what you do with it that I mean, it's just a mathematical tool, right? But the extent to which data sets that are widely used have biases just baked into them, and then you would naively be using these data sets not realizing that you were perpetuating a bias that you had no idea was there, but just that very awareness of the extent of the widely used data sets that are biased for a number of reasons, some intentionally, some historically, some from omission, but for whatever reason, that just has to be part of the thinking going into the process. I mean, and so more careful review of data sets themselves and what's in them or what's not in them, I think is really imperative.
And I think that goes true. That should technically hold true for projects that are or are not AI. It's somewhat refreshing to know that this has become a topic that we are openly discussing, but this problem has been there for many, many, many years, and we've been doing research with these data sets, just not using AI, and we like to blame the machine and saying that the algorithm is going to be biased because it can't tell any different, but it's not that people can always tell the difference either. And so I think that, in some ways it's encouraging that it is a topic of conversation. I think some of the projects that we really need to work at are foundational changes that are very difficult to answer in the time span of traditional grants. And so how do we actually create calls that are reasonable in terms of land, milestones that we can actually achieve and are attainable and that we can actually build upon, I think are things that would be worth considering in terms of how the sponsors actually design their funding mechanisms.
And maybe bring a couple of ideas that have come from our Canadian Institutes for Health Research on how you try and move some of these agendas forward, because there's time, the traditional granting frameworks don't always work. So they've experimented with things like, in a series of grants, say you're interested in the issue of addressing bias in AI, require all of your grants in that field to take 10% of their funding to address the issue of bias and to collaborate with the other funded teams on how they're dealing with doing bias. They did that for team grants in primary care. They said, you guys all have to collaborate. This percentage of your budget is for collaborating, and you're going to work on a common evaluation framework. Another set of things has been the strategy for patient-oriented research centers, where they have infrastructure funding that set up teams that have methodology and in some cases data, and then their obligation is to put at least 50% of their staff effort into supporting researchers in the community within that structure, and it provided opportunities for people to get pilot work, funding, methodology support for writing their own grants in the area. And so networks of the different institutes supporting each other in the common areas where they would like researchers to collaborate.
All right. We've got about 5 minutes left in the panel, so finish it up, and then we'll go to.
That I think there's an opportunity to kind of change the fundamental way we review the grants that come in. I think I've mentioned this before to Roxanne, but we're based on 5 criteria, right? Significance, innovation. One of those criteria, or an additional criteria, should be bias and ethics, right? And really forcing investigators to think about, is their data biased? Is their approach ethical? What types of mitigation strategies are they taking to address this? I think that would be a real key point. And then the second is on team diversity. And I know that recently in the past, there's like a limit of how much NIH dollars any individual can get. But we can also push that a little further and really think about team diversity on the grants that are coming in, and not just at the PI level, right? Because we have the co-investigators, but at the staff level, at the postdoctoral level, and really just pushing that's a criteria that you're going to be looking at is team diversity. So those are 2 opportunities.
Piggybacking off of what Tina said, I would say that in terms of if we're going to have bias be a criterion for funding, we need to also train the reviewers to even know what that looks like, and to make sure that they're actually looking and understanding that versus just completing their medical records in the study section, which people do. And then the other thing is, in terms of diversity of funding, we need to think about the institutions getting funded too. And I say that having only worked at R1 institutions, but when I just was at the AACR Disparities meeting, and there's a lot of great work happening at HBCUs. There's a lot of great work happening at institutions many of you will never have heard of. And it's really hard for them to get their foot in the door for federal funding. And I think that is something that we need to put more of our mind towards as a community. And I think that could be a priority of the NCI as well, or NIH as well.
All right. Michael.
So given there's only 5 minutes left, I'll go with a couple brief comments and then something to think about. So in terms of data and people being unwilling to share certain types of data, I mean, it's interesting, people have Facebook accounts with all sorts of information about themselves, right? How many people download an app and click, yeah, I agree to the terms and conditions without having read the terms and conditions? So maybe we need to think about what it is about their medical data that they're holding back, or not filling out 90% of a form, for instance. Why are they reluctant to give answers to certain questions that we're asking when that information is probably out there anyway, and they don't realize that it's out there, right? They're getting ads that are tailored to whatever email they're getting, right? So just something to think about in terms of data collection and maybe explaining to people how their data will be used. And it's not different probably from how all the data that's already out there is being used. Related to that, pardon my ignorance, but I heard about federated data sets today, and I don't really know much about that. But in talking with Eric and others, when we're talking about drug discovery and trying to get data sets, right, for generating small molecules and mutations of compounds and things like that, trying to work with industry is going to be difficult. Nobody's going to want to give up that data that they have in their own data banks. So how does this idea of federated data sets play into that? And is that somehow a way that we can get access to that data without having the data.
All right. Any reactions to Mike's comments?
That's a valid question, absolutely important. I think one of the ways to do that requires the privacy preserving bit to be solved. I think once we have that privacy preservation in place, more institutions will be willing to come to the table and understand that their data will be analyzed, accessed, but not really leave their premises. So I think that privacy preservation holds the key to that.
Yeah, the way federated learning works right now is that you need a high performance compute cluster of your own to actually do, to actually run that data yourself. You need a team of engineers. And as Caroline pointed out earlier, you need to get the plugs right. So you need to be making sure you're drawing from the exact same distribution of the same types of patients with the same inclusion and exclusion. It all gets, it's very complicated, and I see a future where it might be easier, but yeah, it doesn't solve all the problems. I hoped it would solve all the problems, but it doesn't.
And maybe I think people may have been using the word in different ways. So there's different ways of thinking about federating and different ways that they may be able to do that. One is to physically, to actually bring the data together in a common place, even if it's on a temporary basis, and release it back. So, pull the data elements that are required, use them in a secure data environment as Amber described, do your analysis. The end of the day, that is retired and it's not there anymore, so no one's permanently lost their data. It's been able to be used and it goes back, as opposed to kind of the distributed analysis model of federation, where you're actually just writing the analysis code and distributing it out to individual data sets and pulling it back later. So there are different challenges to them. I think there's the distributed analysis has less privacy concerns sometimes for the companies, but maybe technically more difficult in terms of harmonizing all the data in advance because you don't have a copy of it to work with.
So I completely agree with that. I mean, I think that federating data is easy. Federating analysis is hard because what people usually wind up doing is exactly what you said in the first instance, which is that you fundamentally pull all the data back together because you know how to do the analysis in one spot and then you can put it all back. That, of course, doesn't work on really, really large data sets. And in fact, that's the whole point of a federated data set, is that you have it all distributed. So then you really want to do sequential learning where you're going to use the data where it lives. And then you either have put a lot of compute remote, or you have algorithms that we actually don't know quite how to do yet. I mean, that's a research problem of how to do that learning on distributed data sets. People are working on that. That's not solved. That's not a solved problem.
All right. I think with that, we'll wrap up our panel. Let's give our panelists another round of applause. And again, presenters from yesterday, today, tomorrow, we're going to meet out there for a photo. We'll start the breakouts roughly around 4 o'clock, which is about 15 minutes from now. Okay, 4:03 is about 15 minutes from now. And rooms 123, 218, and 223. So, see you soon.
I know. Okay, and it's how to predict traffic.
Yeah. Oh, really? Oh, that's okay.
Persistent discrimination, both gender and race, in the science.
Yes, presenters. We're going to get your picture taken.
Frederick's on the panel? Oh.
I think we've had a Hood student walk in. Awesome. We have another Hood student. We got the second one. We're doubling, all right. We're going to wait a little longer. We'll get up to 4. All right, so we're going to actually turn this into a nice panel. We have Jonas here who's going to be moderating our panel. You can manage the panel. I'm just going to kind of set it up, put a little context around it. So for about the next, I don't know, 20, 25 minutes, is that what we got here? 45 minutes, okay. So we go until 5:15. Talking about, really about education issues, education opportunities and things of that nature. We had, in the sessions that we heard about today, there were workforce issues, there were topics there about how do we bring people together, what are the backgrounds, what are the skill sets, all these types of things that we need to talk about. So we decided as we were planning this symposium to put an element in that would be talking about those, but also then make sure we would invite our students from Hood College to come and join us so that they can actually learn about those aspects, but things that they can also ask questions. Because we have 2 representative students here joining us. I don't know what we need to do to bring college students into this. Do we have to have pizza or something? Pizza? Yeah. It's pizza, all right. Does Domino's deliver in 30 minutes? And if we get, anyway. But the long and the short of it is we're going to be talking about that. And this is really for the 2 of you that are here, thank you for coming. You got a series of experts in front of you to actually, you can ask them questions that you want. And in many ways, this panel is for you. So we'll help prompt and provide questions and context and things like that. But seriously, if you feel compelled or even inclined to ask a question, just ask it. We're all very comfortable here. We're relaxed, and away we go.
But if you could even say
Yes? No, Jonas is going to take care of introducing everyone. Away we go.
And I would also make the point that this is for students and people considering different career paths. I see some more personal people over there. So some of your people are considering career paths that include a bigger emphasis on the science, AI, and so on. So this is for everybody that is considering. Actually, that was my opening spiel, is that we're trying to solve two problems here. One is our desire to find people that are aligned with the challenges and opportunities of AI. And the other problem is your problem, that you are looking for people that will hire you following challenges and opportunities that they've identified. So we'll start by introducing the panel. I'm just the moderator. So
Use your microphone.
Because
not everyone can.
Oh, not close enough. So I'm Chief Data Scientist for the prevention side of the intramural program at NCI. And so now let's start with you.
Yeah, hi, so I'm Tina Hernandez Busard. I'm Associate Professor at Stanford University. And I'm directing our CTSA grant for the informatics core, and my work involves developing and applying AI solutions to improve healthcare and patient outcomes.
Great. Hi, everyone. I'm James Lillard. I'm a professor of immunology at Morehouse School of Medicine. I'm also the Senior Associate Dean for Research and Innovation. So in that administrative role, I work a lot with developing external partnerships, like with Frederick National Laboratory, for example, but also companies like Novartis and Merck and GlaxoSmithKline and on and on. And in that role, where I'm typically trying to foster research collaborations, it goes hand in hand with internships and job placement, career strategies for our students.
Hello everyone, I'm Stephanie Harmon. I'm a staff scientist at the NCI in the Artificial Intelligence Resource. And I guess my fresh perspective is I'm still trying to make it. I'm very early in my career, so maybe I can offer that perspective. I've been at NIH as a postdoc and then now as a staff scientist for a couple years, and happy to be on the panel.
My name's Amber Simpson. I'm a Canada Research Chair in Biomedical Computing and Informatics, so I'm a computer scientist. I'm a professor of computing. I'm also a professor of health sciences. I supervise graduate students and undergraduate students in all kinds of programs, from epidemiology to statistics, data science, computer science, health sciences, engineering physics, engineering math, because everybody does data science now. And I find that it's integrated into every program in some way, whether students actually explicitly take a class at the university or they take a Coursera class. You have a Coursera class, right? Yeah, yeah. So that's a great way to get students in. Yeah, so I'm from Queen's University. One of our missions is undergraduate education. So we're very interested in the idea of training the next generation of data scientists for a workforce.
So this is the point where the students either ask questions or we ask you questions. So, all right.
Any questions? Not yet. All right.
Hello everyone. My name is Mukul. First of all, thank you.
Talk into the microphone.
Hello. Hi. My name is Mukul. I work in the Frederick National Labs. No? Still not? Hello? Hello? I'll start again. My name is Mukul. I work in the Frederick National Labs, and I'm studying bioinformatics at Johns Hopkins part-time. First, and thank you for everyone to answer my questions, like Dr. Jonas, Dr. Chung right over here. So the question I have for the panel is, what are the good sources where I can just go practice AI, machine learning on data? I mean, I know we can get data, download data from TCGA. So any recommendations where I can just go practice what I learned? Say, right now I'm taking classes on algorithms, so where should I go and just download a data set and like come up with a hypothesis, something like just practice. So any suggestions? Thank you.
So I can start. We offer a Coursera course through Stanford University that has a capstone project. So it takes you through 5 different levels of AI development, U.S. healthcare system, evaluations, deployment, and through that we work on building a capstone project and provide data for you to work through the coursework. So there's a lot of those Coursera courses that are available that have data associated with them. But then there's also a lot of free data sources such as the Mimic data set, which is an EHR data set that's publicly available to ask different kinds of questions. And there's tons of hackathons and things like that that you can see. We do a lot of hackathons associated with different symposiums and different centers, so there's a lot of opportunities through those.
I think there's an underlying question here, just to make sure it's covered, which is people make an investment in acquiring skills, then finding a path to the place where problems are being solved, it's not always trivial, and that seems to come across some of the conversations we had in the corridor.
So Hopkins has a really nice data science online course that you can take. I think it's in biostatistics, but I would recommend that as well while you're doing, you know, all the other things you're doing. But Coursera is a great idea. Find an open data source that appeals to you in some way, that, you know, asks a question that you're interested in. It could be Mimics, it could be other ones. There's other data repos out there, and just give it a try. Look at Kaggle. Look at some of the open source challenges, right? So Kaggle is a great one, and there's lots of other ones as well.
I also heard you were looking for opportunities as well, right, after training. Did I understand? Yeah. So I think developing relationships in the industry and the business are important. So just like you're doing today, coming to conferences like this and networking. More, you know, unfortunately, it's often who you know, and it's timing. So if you know, you've got to work the room and ask questions and make yourself available, right?
Just to build on that, some of the best advice I got from one of my mentors was, for every meeting you go to, you should have 3 objectives. One is meet a new person, make a contact. Then it was cards, get their business card and email them, you know, make that contact. The second thing was learn a new area or topic or something that interests you. And the third thing was share your research with somebody. So 3 main things when you're networking. You really want to get your name out there. It's not just, you've got to talk to people and network and share your ideas and learn. It's good advice that I got.
And you can do that networking in the challenges as well. All of these challenges, people are all over the forums. You can talk with them. You're working on the same problem. So you can learn from them as well. They can learn from you. So it's not that it has to be face-to-face and you're going up and it's very intimidating to go up to other people. It could also be in an online setting.
So I found out upstairs on the window there is a sign announcing a Hood data. I'm not sure if you guys noticed this. So we have 2 Hood students here. Maybe they want to tell us something about the Hood data initiative. Oh, I'm sorry, yes. So the question, sorry,
you have to put it in your mouth.
In your mouth. So they just signed upstairs announcing a new program at Hood. Apparently it's called Hood Data or Data Hood. And so I wonder if this is something you guys are aware of, and is this the reason why you're here, or it just happened by accident? No.
What's your current major? Pre-med? Coming down there with a microphone. We're going to our interactive part of the day.
My major is pre-vet.
And so you're thinking about changing it to?
I don't know yet.
Well, I'll tell you, there's a lot of people that do computation, like they'll do pre-med, but they'll also take some other data science courses and then go into medical school with, you know, a repertoire in data science.
Yeah, I really like that mix, you know, having a data science background. So Morehouse School of Medicine is a freestanding medical school. You know, we get literally 9,000 applications every year for maybe 125, 150 seats. So having some way to make yourself stand out some way. Biology majors are good, but something data science would really help in that regard.
What brought you here? Can I ask you? Yeah, so we get emails. So that I'm an accounting major, so I'm just here to kind of represent the student body.
Yeah, yeah. So accounting, very related to data science. And also like a lot of accounting. Yeah, yeah, of course. Yeah.
So maybe we can take this chance also to approach this workforce development issue that hangs over all of these questions and these preoccupations. So if you don't mind, I'll run through the panel of question, which is, what are you looking for in the people you're hiring now that you're not getting? So the things that are missing and you need and your team doesn't have, because these are new frontiers.
Was it starting with me? Oh, I should pay more attention. So the students that we have now can learn anything. And so they're not hindered by the silos and saying, you know, I'm a history major, I don't do that. That was kind of the way it was when I went through. They're just not like that now, right? Like everything's online, everything's social media, those silos are just completely gone. So in my mind, you know, anything that they don't know, you can teach them. And in some ways, that's even better, because then they're not getting a corrupted knowledge, they're getting the knowledge that you want them to have, right? So I think you can train anybody to do anything. When I'm recruiting people for the lab, I really, you know, the primary indicator of success is interest and whether they're motivated, right? And whether they're inspired and passionate about what we're doing. And if that's the case, then a lot of the other stuff, I mean, if you've got an undergrad degree, then you probably did fine, right? So for me, it's, you know, if you can attract people that are really passionate about what's happening in the lab, that's the biggest indicator of success.
I agree with that. And at the NIH, we don't have students, but we have fellows. So we typically, for example, in our group, at any given time, we'll have postdoctoral fellows, we'll have medical fellows who could be visiting from another institution, another country. We'll have medical students who have taken a leave from school to come and do research with us for a year. And we have post-bac fellows who are typically students who just finished their bachelor's degree and they're trying to decide, do I want to go to med school, do I want to go to grad school? And the single unifying thing about all of those good candidates is just, do they have interest and are they passionate about it? I don't care if you only code in R and I need you to work in Python. We'll teach you Python. I don't care if you don't know how to code at all and you're a medical student who's interested in AI. We'll find a way to work with it if you're willing to put in the, you know, the dedicated time and have the genuine interest.
You know, ditto and ditto. It's also important for our faculty recruits, let's say, that they're well-rounded. To your point, it's not enough anymore just to be, you have to be open and willing to learn different disciplines, and I'm an immunologist that's somehow doing precision health implementation science, it's also meeting the needs of my research as well and the institution's needs, so you have to be flexible, I think.
Yeah, and I agree. Interest is a key factor, and it's very clear when you get, because I get a lot of emails about people interested in my lab. It's very clear when it's been an email that can be sent to 35, 50, 100 other faculty versus one that's written tailored to me. And to be honest, I only look at the ones that are tailored to my group. I want to be in your group because you did this study and I really like this, or I'm really interested in this aspect. So it's really tailoring those emails to fit the group you're looking at. And then I think that makes a big difference.
We're on to you when you send us an email and you've copied and pasted in a different font than the rest of the email a title of the paper, you know, so they just, you know, there's this random thing cut and pasted in a different font, we're on to you. We know that you didn't really read the paper.
And I think we have a question over there.
Yes. Hi. My question is about how to establish a PhD in data science. Okay. Our institution, we have a multidisciplinary department, but the faculty who are working on the project are from computer science, mathematics, physics, chemistry, everybody in the college. And we're trying to find ways to define a program that can appeal to all the majors in STEM. And we're finding it very difficult because each department is pulling their side and say, you need to have this, you need to have that. So if you could share your experience and your opinion and your advice on how to approach this, that'd be really helpful.
All right, so that's a transdisciplinary question. It's not an easy one.
So computer science loves to build obstacles to things, right? Like we're very much a discipline of, oh, you're not a real computer scientist because you do applied work. Not that I've ever heard that. Yeah, I hear that all the time. And so I think it's kind of interesting that you have a chance to start from scratch and not look at the other programs, right? And not do the thing that everybody else does. I don't see the PhD as needing to be this thing that's up on some pedestal, right? Like you could design a program that makes sense for your people and that does extremely high quality research as part of it. And I don't think you necessarily have to fit the mold of what another group is doing. You could do something really interdisciplinary and work that into the requirements of that program.
I'm coming from a medical physics background, so that the requirements there are pretty strict depending on the program, but at least my prior institution, I think one thing that they did well, which is the University of Wisconsin, was if you wanted to go off the rails, you could, basically. It's the blue sky approach. So I finished my first year of core curriculum in medical physics, and then I started taking cancer biology and bioinformatics, and I worked through it as long as my committee approved it and my department approved it. They knew that was my plan and my path. And so it really, having students be able to tailor their own programs, I think is really powerful. I'm sure other universities are doing it as well. It's just, this was my only experience, yeah.
Yeah, right. We do that a lot at Morehouse School of Medicine. But it's important that you, I feel it's important you establish good mentors, mentorship, and keep in touch with them. It goes both ways, you know. There's good mentors, but there has to be a good mentee that's active and engaging and seeks knowledge. Now, you can take the advice you're given, the mentorship, with a grain of salt, but you know, you should seek those mentors out, and they could be in different disciplines as well. That'll help you triangulate, you know, especially if you're creating something new. I think that might serve you well. The other thing I wish I did more of when I was your age was identifying advocates for you as well. It's one thing to have a mentor that gives you advice, but someone that can advocate for you could really be powerful.
Absolutely, and I always say, just building on that, you need a really good mentor and you need a really good sponsor. And a sponsor is somebody who is going to put your name in the hat, is going to put your name on the table when there's opportunities, is going to, you know, not necessarily your mentor, but just have other avenues that they can bring to you and open doors for you, and those are so important, not only in just throughout your entire career trajectory. I think it's really important.
And just you just made me think of something. You know, someone in the audience is a great advocate for me. You know, it's not the head of the head of NCI or anything like that, but these advocates or champions could come in different forms.
Thank you for your question. There are indeed many departments of biomedical data science emerging now. You probably noticed that in different places. So it may be also interesting to compare them.
Sorry, I didn't catch what you said.
So there are a number of biomedical data science departments emerging now, sometimes on top of departments of bioinformatics or biomedical informatics. So it's a name that is catching on, and there are reasons. Different institutions approach it differently. It may be interesting for you to compare them to see which ones would fit your scenario.
Now, you're a faculty member, correct? Are you faculty or are you a student?
I'm a faculty.
You're faculty, right? Yes, you're trying to start a new program.
You think of me as a student. So I'm a faculty, and almost every department in the college, the STEM college, is involved one way or the other in designing the. But thank you very much for your input. Thank you very much.
Just to close that point on other models, I just remember NSF had a data science working group some years ago, and there was work by two anthropologists, I can't remember their names, where they were discussing models of learning. So they said there were three. There is a discipline where you have to be good at one thing, the interdisciplinary, you have to be good at more than one thing, and the transdisciplinary, where you can be bad at all of them. But with that, being bad means being good at something else, the ability to integrate and so on. And I thought it was something we don't typically think about, models of learning, the anthropology of epistemologies and that sort of thing. That's a great question.
So if I understand well, you're saying we should expand it maybe to include other faculty from the education department?
I think that there are some patterns you're already picking from the committee. For instance, the idea of capstone projects, of self-driven initiatives with a mentor. So it's a different type of, it's a different model of learning. So what I remember from that presentation is that it relies on narratives that are built in the process of learning. And I also remember something that puzzled me a lot at the time, is that a typical example of that model of learning is hunting. I'm not a hunter, but apparently hunters learn by listening to narratives of fellow hunters around the fireplace. So we also have fireplaces in data science. Actually, there is a place called Fireplace, right? No, Fire Camp. Fire Camp, yeah. And so we are kind of creating the same model, socializing learning by making friends around the fireplace, comparing notes. And maybe your institution is already looking for that sort of dynamic.
I mean, if you have really good PhD students, it almost doesn't matter what courses they take and what structure they have, right? You just want to get them to the research as soon as you possibly can. That's my goal as a supervisor, is to get them in the lab, get them learning the hands-on stuff as soon as possible. And I think if you keep that in mind and then pick the requirements around that's how I'd build a PhD program.
Okay, great. Thank you very much.
Hello, my name is Walter Hubert. I'm from the National Cancer Institute in Frederick. I have various responsibilities, but the most pleasurable one is the one mentoring interns. We have high school interns, which is for the NIH standards, somewhat on the rare side. And we have, of course, college age interns. In order to pave and develop the pipeline of talent, as I call it, I also interact with Frederick County Public Schools in the LINKS program, which is a less traditional way of bringing professionals to the high school to explain about their career paths. Now, you all are accomplished professionals now. The question I would ask, or the questions I might want to, the knowledge I would like to convey to 9th and 10th graders is, if you were thinking back, what would you have liked to know as a 9th or 10th grader to shape your career perhaps better or at least as successful as it is now?
Regrets. Talking about regrets, right? Things we didn't do. I maybe offer a tentative answer. I think, for instance, we all now face a challenge of implementation science because AI is doing well enough that other people want to consume it, but we've mostly been producing it for ourselves. So if I was a computer science student, trying to answer your question, I would say software engineering should have been in my radar because I get the feeling data science and AI is identifying lots of blind corners in different careers, and I think that's true for us as it is for the students. We share that with the students for sure.
I think along the same lines as what we just talked about with the PhD programs, often very early, middle school, high school, we feel the pressure to specialize. And I don't think that's the right approach. I think the pressure should be on learning and creativity and exploring what you're actually interested in, as opposed to being pushed down a certain pipeline.
How about what we don't regret, right? I've done a lot of things that I don't regret, like taking time between my, before my PhD, changing my major 3 or 4 times. You know, I don't regret any of those. I think I really went and explored and tried different things, and I finally found something, and I'm like, oh, this is for me. You know, this is what I like to do. And so things that I don't regret are making changes to my major and really, you know, going down the path that I thought was right. I don't regret taking time off and taking a pause to explore other things, which really opened opportunities for me. So there's a lot of things that, like that happened during my schooling that I don't regret.
Yeah, I would agree. You know, and as I look back to some of the interns I may have trained, I think a common denominator of some of their success was coming from a discipline, undergraduate degree maybe, that involves some type of rigorous critical thinking and the ability to complete a project. Now, engineering for me, a double E computer science engineering, so we always have these projects. Learned how to work as a team. You know, being on a team in college or high school taught teamwork as well. But even things like music, you know, some of the most gifted postdocs and graduate students had a music background, and I'm not sure how the brain functions like that, but you know, being able to the discipline of practice, perhaps putting pen to paper and creating, I don't know, some things that seem helpful.
If you don't mind, I'm going to use your training in computer science and engineering. That's a great example. So computer science went through this push towards engineering, and I assume that your question is also inspired by the mission of a national lab having to have an AI engineering component. Do I understand that correctly?
I'm not so sure if we have, actually, there's a question probably Eric Stolberg could answer better. On the Frederick National Laboratory investment on AI specialties and things like that. Eric, would you like to comment on that?
What's the question you want me to comment on? Oh, the engineering side of AI. Wow. Where do I start? I'm just thinking about from a perspective. I can talk about career and things like that, but I will say that, you know, what you've been saying about being multidisciplinary is really important. I actually started as a computer science major and found that I needed to challenge myself more. And you know, one of the things that happened early on for me is I was working for a company and it went through a staff reduction. I wasn't reduced. I stayed with the company, but it made me make a decision. Did I want to go deep or general, right? And I opted to basically move into a general path and look at what I could do well, but then how many different places would what I do well apply. I'm going to bring that back to Frederick National Lab, and that's one of the things that I found about Frederick National Lab over the past few years is that those broad experiences, those working with different organizations, working with different industries, doing adjunct and teaching and things of that nature, all come back in the things that we've done over the past few years because it provides that interface to work well with so many different people. And I think that gets us back to what Frederick National Lab has for the AI resources is how do we actually serve as that hub for the community in those efforts that actually can serve the community at large as that national independent laboratory for those things that take a long sustained effort, that provide those resources, that give you the engineering implementation so that you can have the robustness, sometimes being the place where you can evaluate or define and work with the community and understand what the standards are. So, you know, putting it back from in that context, the students and things that we find, and I've had a chance to work with students from lots of different disciplines, from undergraduates to adults and things of that nature, is exactly what you were saying. They're interested, they're motivated, and then something that you find as an application allows them to bring all of that together and really drive things forward. The one thing I haven't heard yet is passion. That's the one thing that really can drive success, is to have passion for the things that you do, and really having that motivation to change things and make things better.
I do agree here that I think passion for something is a strongest driver perhaps for pursuing a career. We can't quite pinpoint it. Last question to you all. Did you have mentors and advocates in high school when you were going to school? Someone who recognized your talent, and then someone who said, this is directions you should take. Thank you.
Thank you. It's a great discussion. We reached the 5:15 mark. Is that right?
Yes.
All right. So thank you for your participation, for allowing this bidirectional route. So let's compliment you.
The day is done. Thank you. Yes, to answer the question, reception and networking for the next half hour. We heard networking was important, or excuse me, for the next hour over in the Whitaker Campus Commons. And then dinner is at 6:15 to 7:30. So start networking.